Thank you, Lord, that you have been with us in this moment. We ask also to be with us at the rest of the day. We ask for this and we're not forcing you. In the name of Jesus, we pray. Amen.
Thank you very much. We are now feeling that we have come to the right place. We have asked for the Almighty to be with us. In terms of our program for today, colleagues, we want to rush straight to the business of the day, which is about impacting, engaging, as well as sharing some experience for us when it comes to issues that are in the base of the human rights for health. But before I proceed, I do know that sometimes abantu bayakwazi ukukhala emngcwabeni orongo. So I must just confirm and announce that we are here for the Global HRH Symposium. So that if maybe, just maybe by chance you were following people and you are not sure, you can stay though because you'll still learn a lot. But if you feel that you are going to miss out on where you were supposed to go, you'll just find a way to just sneak out and go to the right venue. So here we are gathered today just as invited, hosted by WSU, Walter Sisulu University, especially the health faculty, for what has been termed the Global Center for Human Resources for Health Intelligence Symposium. And I would like to welcome everybody who is here. But of course, in the midst, we do have and we acknowledge the presence of the National Department of Health, as led by the DDG responsible for hospitals, human resources for health and infrastructure. We also acknowledge ECDOH, Eastern Cape Department of Health, that is also represented by a general manager responsible for, he usually says, I'm responsible for legislative work. Just give me legislative work, planning and M&E, Professor Moko. We are also having and acknowledging that there is a representation from the College of Medicine in South Africa, as well as Nelson Mandela University, our medical school, as represented by Professor Modley. The South African Medical Association has also made an effort to be part of this session, as represented by Dr. Sillo. I would like to also acknowledge sincerely, and I know especially whenever I come to this side of the Eastern Cape, we know the value add, the relationship and the role that is played by the House of Traditional Leaders. So we do acknowledge that we also have a stakeholder in the form of House of Traditional Leaders. But of course, in the health space, we don't work alone. We also have social partners that we have also extended an invitation to come through. And we would acknowledge as much as they are still to be coming and notifying us, but we do acknowledge that we have invited and do have some members in the attendance. And of course, we also acknowledge that we are in the midst of academics, and we do appreciate that in your busy schedule of writing, reviewing, and rejecting some papers, you just decided to come and be part of us and grace this occasion. We would be chucked out of this place if we do not acknowledge the presence of the Office of the CEO of Nelson Mandela Academic Hospital, if we don't acknowledge him. So we also acknowledge his presence. And of course, the speakers, as they are lined up, we do acknowledge their attendance and appreciate that they've made time. I was just trying to ensure that all of us, we feel that we are part of this session, and we do acknowledge that we are in the right place and ensuring that we would be free to participate, to listen, and to engage as we are about to start with the program of the day.
We can't miss acknowledging Dr. Bayeni, who's the program director for the day.
Oh, yeah.
We can't.
I'll just stop the program and go home.
We can't miss that. Secondly, we can't miss acknowledge that there are people online who have joined with us online. For example, we have Dr. Professor Rohana Joshi, and also we have Dr. Blake Angel, and we also have Ms. Kitty Mike, who are online, have joined online with us, and other guests online at large. Thank you.
Thank you very much. And I hope every one of us now feels very welcome and is ready to participate and engage in terms of the program flow for the day. But of course, ours is just to request and call upon speakers to come to the floor, and they have been given a task to do. And as a result, we will just move straight now and have the purpose of the day, which is linked to the opening address that will be rendered by Dr. El Sobwekwe. And we would like you to come to the fore and render that item for us. Can we please give a round of applause, please? Special something. Yeah, bethu manibonge iqandile libe lamazwi. So anifuna ubonga ngesingisi.
WSU abantu bahleli phansi. Xa kunzima kubotshwa nezibhityileyo, yiloo nto nam nibona ndiphambi kwenu ndiyinkosazana yamajwarha, ooYarho Khathitho Mnango, oovumisa isala kulandelwa usijekula umsila, dolo limnyama kuthandaza. Umntu omhle noba sephethe izikhali, ungabona usulimala niyazibonela nani. Ndithi xa nditshoyo ke ndiphahliwe, ndizawuthetha ngoba ndingumntu ophahliweyo. Kaloku mna ndingumabunjwe bhidlika njengodaka. Into eyabunjwa ngoosikhuza bahluleke besithi ethos melish, ngadlula lathi gulukuqunda ngena ku-medical ethics. Ndiyabhotisa xa nditshoyo, andifuni kabathembu ze banomona, ngoba kaloku lo ngumhlaba wabathembu. Xa ndilapha funeke ndi-acknowledge, ndiyabazi oomadlomo zinto ezinomona, ndiyabazi ooyeyeye ovela bambhentsele bazawukhalaza bandigxothe endaweni yabo. Xa nditshoyo ke uba bendiyindoda ngendikhahlela, kodwa ke into yamanyenza leyo. Sendoshiya ke ndithi ke mna ke kuni ke bathembukazi, ze nitsho nithi oobhuti bethu babulisile, ngoba kaloku lo ngumhlaba weenkosi esikolo sime kuwo. Sazisa ke iinkosi ezidlulileyo, ezikhoyo, eziphetheyo, kanti siyazazisa nezizayo, ngoba kaloku uba siyenzi loo nto azinoba nandawo emhlabeni woyise. Ndithi xa nditshoyo ke ndiyabhotisa. Ladies and gentlemen, our esteemed guests, our distinguished speakers, I won't mention you one by one because you've already been acknowledged. This is my way of saying to you good morning. I would like to start it by saying, they've said this is for health intelligence. And I think the best way to start the day is in the mighty words of Abraham Lincoln. That is meant for health professionals like yourselves. This motivation underscores the importance of shaping the future of health through perseverance,
and a collective effort. In his direct words, he says, the best way to predict the future is to create it. That is why we are here. It is both an honor and genuine pleasure to welcome all of you to this international symposium that is hosted by Walter Sisulu University in the Eastern Cape of the Republic of South Africa. Hence, we are so wide and we have guests online on Teams, YouTube and Facebook. Niyasibona Moses phambili. We will discuss human resources for health intelligence. This is where our collective minds will make a difference. I'm thrilled to see such a remarkable gathering. It's full of experts, it's full of thinkers, and it's packed with professionals who are as passionate about healthcare as I am. Though I'm suspicious some of you came for the good lunch that we normally offer, and also escaping the meetings that were scheduled by their bosses. Either way, I'm glad that you are here. As we kick off this symposium, I'd like to remind you that we are about to embark on deep conversations. Yes, it's about health, workforce, it's about our resource limitations and the strategies that are going to guide us as South Africans in the healthcare system and for our future. And I must say, there's no better time than now to address these topics, especially given the high demand that is required for change. And I'm not just talking about the growing pressure that is brought about by the National Health Insurance to finally get off the ground. Nisibona nje simatasatasa, siphithizeliswa ichuvane yale emampondweni. Uthiwa yasuka kuba yayidinwe kuchitha-chitha apho ihlala khona, yayeka ngokuba nguchitha yazoba ngumakhi kweli cala lamampondo, izizamela. Kodwa akakho nto sinyamezele ngokuthi usaqala ukwakhenye aqalise enye asithubi kwanto kodwa siqala yonke into. Kodwa ke loo nto ayinamsebenzi ngoba uAlbert Einstein reminded us powerfully that even in the most challenging of times, there are opportunities for growth. This is where today's symposium comes in. As we've gathered the experts that you've heard from across the globe, we've got health economists, we've got national directors of health, we've got leaders in human resource for health. They are going to share their insights and yes, the strategies that we need for tackling the big questions. We're here to explore how we can strengthen our health workforce in the face of all the challenges that we have mentioned. And whilst we're juggling with the limited resources, we will find effective ways to implement our NHI without causing a nationwide meltdown, because we are experts after all, and we are professionals. Well, as I've indicated, we will be talking about workforce planning, recruitment, training, retention, career development, migration, skills mix, to mention but a few. And all these topics will require your undivided attention. I hope that you will focus, even though some of you will have rambling tummies by the time we reach 12, but please be patient. Our focus areas will be the challenges that we have with the health workforce. We'll take a closer look at these challenges, the shortages. I'm talking about burnout. Let's not forget the temptation of looking for a fatter paycheck abroad. Yes, it is welcome, but at what cost when you look at our healthcare? We've got resource limitations. It's no secret that our resources are limited in South Africa, but it's not peculiar to us. It's all over the globe. You find waiting lists everywhere. And yes, we have to figure out how to stretch our budget, like the magician when they pull out their rabbit out of the box. We'll also look at the thinkers that we have here for strategies for the South African workforce. And here, it is where the rubber will meet the road. As we discuss the future of the South African health workforce, we'll dig into practical skills, we'll dig into sustainable strategies, and we'll find ways to strengthen the system of our country. It's time to get serious, but also we must be a little creative, because when it comes to solving big problems, sometimes it helps to think outside the box, especially doctors who are always in the box. So as we go through today's sessions, I will encourage all of you, please do participate, ask the tough questions, and maybe share a joke or two. Asikho serious ngaleyo ndlela. It's going to be a long, challenging road that's ahead of us, and therefore it's still the best thing that we laugh here and then. After all, it's not only medicine that gets us well. Together we have the opportunity today to shape the future where healthcare is not only accessible, but effective, sustainable, and yes, possible, even a little bit enjoyable for those who are dedicating their lives to it. I'm thankful for you for being here again, and I look forward to the incredible conversations that we are going to have. Ayisanqabanga ke madoda nalapha kusemampondweni. Apha ke emampondweni asithuli nje siziyeke iinklasinyana zizihlalele. Senisijonge ke bethuna kangesilale besithunga. Abanye bethu bambejembeje. Ke ichuvana ezikhoyo zizisincede zibonga ithuba zizibike. Kaloku sisenabo apha ekhaya ontombi ekhaya. Ohlalelephi nohleziphi kanti nontombi futhi nabo basanyekile nobuyisiwe nobuyiswa nabo bayafuna kaloku ukuthethiswa. Kodwa ke sesincede ke bantakwethu ningezingenkani njengalachuvane kaMaliya le yafika yadelela lamjendevu wasemsamaliyeni. Zeni bacenge noko nithethe kakuhle nabo. Kaloku nethu umuntu umkwece elapha ecaleni kwakho ubuza impilo nendlebe zitsho zibe nomdla nodlamko womamela. In the words of our icon, Nelson Mandela, let me remind you that we are a people of resilience. And yes, we bounce back from adversity, something every healthcare professional embodies on a daily basis. He says, the greatest glory in living lies not only in never failing, but in rising every time we fall. Dive in and share with us, Enkosi.
Welcoming words. Thank you so much, Dr. Sobekwa. Then at the moment, now we are going to proceed with our program. We are going to call on Dr. Bayeni to introduce our first speaker for the day. Thank you.
Thank you very much. We are now going to be calling upon the first speaker for the day, who has been given a theme to talk on the future of the health workforce in the low-middle income countries, specifically focusing on challenges as well as opportunities that are available. She will be joining us online, and we are introducing to you Professor Rohina, who is a professor for global health at the University School of Population Health at the University of New South Wales, Sydney. She also holds an honorary appointment in the following universities, at the Sydney Medical School, University of Sydney, as well as Walter Sisulu University in South Africa. She completed her undergraduate training at Christian Medical College, Ludhiana in India, as well as a postgraduate training in public health from India. She went further to then pursue and obtained a PhD in medicine from the University of Sydney. Her research program aims to strengthen health workforce and health information system in order to deliver quality health care. As a senior technical advisor and OSHub lead for the Data for Health Innovation Initiative, she has the opportunity to contribute towards strengthening data for health in the Asia-Pacific region. Professor Rohina convene and teach the Global Health and Development course and give lectures for the MGH and MPH as well as BIPH program at the School of Population Health. She supervises master's, PhD, as well as Dr. PH students at the University of South Wales. As a health system researcher, she leads and contributes towards several studies, including, if we may quote, Data for Health Initiative in Papua New Guinea, Solomon Islands, Philippines, India, whereby she also has looked at funding Bloomberg philanthropies. There's an assessment of diabetes prevention and control related interventions in South Asia that she has also contributed to, which was funded by the World Diabetes Foundation. She has gone further to participate in the review and revision of the Community Health Workers Training Program in Fiji, and as well as WHO steps in implementation in Fiji, funded by TFET. She's also been instrumental in the evaluating the impact investment case, as well as the scale up of health promoting schools in Fiji, as well as scaling up of competency of primary care workers to manage epilepsy by task sharing. She continues to also be instrumental in caring for the carers, which is a psychosocial supervision intervention to improve and the quality and sustainability of mental health services in humanitarian context, as well as the program where she also has been influential in the pragmatic randomized controlled clinical trial to support self-management for inhaler device technique and medication adherence among people with chronic obstructive pulmonary disease. Can we give a round of applause and welcome to present to us currently Professor Rohina Joshi. Over to you, ma'am.
Many tests. Can you hear me?
Yes. Yes, you may proceed. We can hear you loud and clear, and we can also see you.
Right.
Thank you.
Right. Thanks so much. Thanks for that very long introduction, which was just not needed, but thanks so much to I'm just super excited to be part of this auspicious day, and I want to convey my best wishes to colleagues at Walter Sisulu University for a day like today. So thank you so much for inviting me. You know what my topic is. So I'm going to start off the traditional custodians of the land on which my university, the University of New South Wales, stands. And I also want to extend that respect to the custodians of the land on which Walter Sisulu University stands. And I really hope that this engagement and this collaboration really bears fruit and respects the traditional custodians on whose legacy, whose knowledge that we share across the nations. So the talk, I've been asked to speak about the future of health workforce, and health workforce sits within the health system as we traditionally see it. So this slide here shows the 6 building blocks, the health system building blocks, in terms of service delivery, workforce, health information systems, medical products, financing, and then finally leadership and governance. And all of these together would ultimately, working together in harmony, would lead to improved health, would have a health system which is responsive to people's needs, would offer that social and financial protection, and have an improved efficiency in terms of delivering those services. But we can't imagine a health system without health workforce. And none of these would be possible without having a health worker. And normally we would think of a doctor, but a health worker is anyone from the doctor to the specialist or the surgeon and everybody in between. So to deliver health services optimally, health systems really need to take care of this workforce and need to train, retain, and sustain the health workforce. And so my talk today is going to be around these 3 pillars. I'll start off with some of the challenges. Some of them were already addressed in the first opening remarks. We often hear these there because that number varies depending upon the type of study. But we know that it's in the order of millions. Within that, if you look at the acute health workforce shortages, they are in Africa, Asia, and Middle East. And of course, there's chronic underinvestment in education and training of health workers. And as we have seen with some of the research that comes out of your university, there is a mismatch between education and employment strategies. And of course, difficulty in deploying health workers to underserved areas. The opening remarks talked about the international migration, which exacerbates this shortfall. And underpinning this, to understand how many doctors or nurses or pharmacists are available, the health information systems for the health workforce are weak. Now, these are some of the headlines that we see. Being an academic, I'm going to draw you to the evidence that is out there. And this slide it shows data from the Global Burden of Disease study. And what we see is the density of physicians per 10,000 population. And the colors range from if it's dark purple, I'm not sure how that is presenting on the screen right now, but it's dark blue or purple. That means it's a very healthy doctor to physician to population ratio. But if you look at the dark reds or browns, that's where there are very few doctors per 10,000 population. And again, I want you to from the perspective of where you are sitting, where you've come from, and also identify where those gaps are. Now, these are doctors. Let's look at nurses' lives. So it's, that story continues in terms of polls that Africa, South Asia, and Southeast Asia, there are huge challenges there. Now, I want to note that this is just looking at aggregate numbers at the national level. If we then disaggregate it by regional or just by rural, urban, again, look at where you are sitting and the areas that you are aware of. Look at the disparity amongst the availability of doctors and nurses, looking at rural and urban regions within countries. So this study then looked at how many health workers are needed for countries to have an effective universal health coverage index. And it's based on a lot of assumptions, but what they said was to reach 80 out of the 100 UHC effective coverage index, the world needs per 10,000 population, about 21 more physicians per 10,000 population, around 71 more nurses, 8 dentistry personnel, and 9 pharmacy-related personnel. So in 2019, if you looked at all of this, the total workforce, it fell short by 6.4 million doctors and about 31 million nurses and midwives. Now, please note the date. This is pre-pandemic, and we know what happened post-pandemic in terms of the health workforce. So there is a need for increased financing, training, employment, and retention strategies for health workers across the globe. So we know that is even more needed in low and middle income countries where there's need for innovation to attain this universal health coverage. Now, just looking at health workforce and looking internally at how some of the challenges faced by the health workforce, just summarized by 4 C's over here. There's changing demographics and chronic conditions. So if you just look at the population, many of the doctors, nurses, health workers are trained more in the acute care, maternal and child conditions, infectious diseases. But now we're looking at chronic conditions, and is our training linked to those sort of changing demographics? We know of the conflict worldwide, but there's also conflict within the workplace. And health workers they are at the front of all of these sort of conflicts that they need to endure. A relatively new aspect is around this culture of the rise of misinformation by social influencers using pseudoscience or actually no science. And then, of course, our health workers work within the complexity of health systems, as I showed you a few slides ago. So considering all of this and then adding COVID and the pandemic, what happened during the pandemic, it's just led to huge burnout amongst the workforce globally. And then it's further exacerbated in low and middle income countries. So enough about the challenges, let's look at the opportunities. And I really liked the opening remarks about creativity and how do we, like in India, there's a word called jugaad. How do we create these new innovative approaches which are part of our health system, but how do we strengthen them further to look towards the future? So as I said, I'm going to talk about workforce from the perspective of training, retaining, and sustaining the health workforce. So let's start off with the first block of training. We are all aware and know about those formal education pathways, but I think also thinking about the informal pathways for capacity building. So in terms of the formal training, there's medicine, dentistry, nursing. Alongside those traditional pathways, also around management and leadership, which is absolutely core to the health system. We can't expect doctors and nurses without training in leadership to suddenly lead these vast organizations or management of hospitals or health systems. Of course, again, we can't just focus on management and cure. We also have to think about that preventive aspect and look at public health, understand policy, health economics, epidemiology, advocacy, health promotion. But I think the future is going to be how do different fields come together? How does medicine engage with law, with engineering, with digital health? How do we merge these different fields so that our workforce is trained and able and skilled to talk to each other, because we've got to think about that comprehensive environment in which people live. So upskilling and reskilling opportunities will absolutely be crucial for career progression. So we really need to rethink formal training as we do in today's day and age. So learning to use technology is something that will be absolutely essential to ensure optimal and efficient delivery of services. For this, health workforce would require lifelong learning for career progression. Upskilling for technology optimally will be a requirement. So what's happening right now is we are delivered technology and we are kind of supposed to learn ourselves. But there needs to be a way in which we are taught to upskill ourselves for career progression. Leadership, mentoring, sponsoring health workers to grow and transform their careers is even more important. Just because you are a medical doctor, you don't need to stay in your particular career. Or if you're a nurse, how can you build your career so that you can go across the different different aspects of health system. And so I think the boundaries between healthcare settings will also diminish as we transform from physician-patient care to more of team-based care. And so those informal training pathways would also include training for team-based care, job sharing, task sharing, or redistribution. I'll move on to staff retention, which is quite a topical, it's a topical issue, not just in South Africa, but in many regions. And again, it's not limited to low and middle income countries. Australia is facing issues with retention of staff as well. So in terms of retention, it's around understanding and implementing methods to motivate and retain staff, and also think of disruptive models of healthcare using evidence and technology. So in terms of retention of skilled health workers, I want to draw upon this study which was led by Professor Sikanduzuma Bunda, who looked at 4 different countries in Southern Africa and studied the effectiveness of return of service schemes for health workforce. And what he found was across the board, first of all, there was really poor health workforce data. He then found that 75% of the beneficiaries defaulted on the return of service scheme. And within that, he found out that beneficiaries who undertake internship training outside of their funding province, they have higher defaulter rates. Now that's within the country. There are issues around they're being trained and money is being spent, but they are not being embedded or retained within the public health system. The second paper was something that we did collaboratively, looking at health workforce immigration. And the recommendations that came out of that paper were that high-income countries must decrease their reliance on international medical graduates, especially from countries which have very critical or severe health worker shortage. Now, having said that, economic migration or migration is a human right, and people should be allowed to move wherever they want to in this world. But I guess one way of looking at it is also partnerships between countries that will enable workforce training and facilitate something called circular migration. So it's not just doctors, nurses, pharmacists, etc., moving from one country to another, but people from other countries also migrating back, enabling this knowledge exchange. And finally, the recommendations for governments in resource-poor settings were around improving planning and investing in healthcare teams with diverse skills. And I'll talk about the diversity of skill sets in a moment. So also thinking about the future of health workforce would involve having this care. And by that disruption, I mean having patient-centered care, the focus on prevention rather than purely treatment. Because as we would hear some of the health economists speaking today, that countries, the world cannot afford purely management. We really need to think about prevention as well. Thinking about community health systems and then embedding technology in healthcare. So my first point within disruptive models is around patient and family-centered care, which involves things like engagement. So not just looking at the liver or the kidney of this patient who is sitting in front of us, but understanding the entire being, that comprehensive aspect of the person, also understanding the social factors that impact that person, which has gone down, who has gone down to get, acquired disease. So that engagement with the family is really important. And for that, we need to think about systems outside of just that doctor-patient relationship. Communication is absolutely key. In many settings, if you are a healthcare professionals, can reflect upon the communications that occur within, within that doctor-patient chamber. It's usually a one-sided communication. But what I am suggesting is that we have this dialogue involving patients and their families, such that there is shared decision-making, considering what works for the patient and their family. Now, this does require a different level of training, because as doctors, our way of training does not involve, that traditional way does not involve these sort of factors outside the biomedical model. The next thing is around community health systems, which actually South Africa is really good at in terms of having community health workers, community health teams. But the idea is to take that community health system and really strengthen and transform it. So this includes things like community health workers, schools, peer groups, religious communities, bringing them together to look at health from a prevention through to palliation, the entire comprehensive approach. Within this, I want to focus a little bit about community health worker programs. noting that there is, one of my colleagues is going to speak specifically about it. But again, South Africa has this program um, primarily focused on infectious diseases and maternal and child care. And here's when I would like to, discuss the opportunity of expanding or transforming that program to include chronic diseases, which is one of the leading causes of premature mortality in your country. So these are just some studies that were done by colleagues of ours across the world, which showcase that community health workers can do more than infectious diseases. They can deliver care for cancer, they can help screen for cancer, they can help with the control of hypertension, and they can also use digital technology to provide quality care in communities. And of course, my point over here is that this community health worker is not the only one. It is a team-based care, and she's then supported by the nurse, the doctor, and the larger primary healthcare team. Talking about digital health, this is a study from the Lancet Digital Health, which looked at various technologies from mobile health, telemedicine, EMRs, use of AI, etc., the impact of that in the performance of the health worker. And so what you see on this slide is a forest plot which shows if it's on the right, if the red dot is on the right of that of the x-axis, it's actually beneficial. So what this study showed was that using digital technology improves the accuracy and efficiency of the healthcare provider in the decision-making process. It reduces time and increases productivity. It makes data accessible quicker. It's much faster and reliable. It helps people acquire knowledge quite quickly. Of course, as you can see, there's some variables that are closer towards the zero, we don't have that evidence, that positive evidence yet. But overall, if we see, digital technology does have a positive impact on health performance. I think as workers, we need to be trained in the use of digital technology. We need to be given digital technology as part of routine care, which will benefit the patients and the population at large. But having said that, while impact health workforce, we really need to make sure that we get it right. We are seeing that specialties such as potentially radiology shift some of its work to AI, and we already see that using radiology, one can pick up lung cancer, it can pick up a bunch of conditions, just run through X-rays through AI, and it can detect conditions which were previously undetected by radiologists. So there is a way in which one could collaborate with AI in a positive way, but that human touch is absolutely irreplaceable in the whole healthcare spectrum. And so I think one of the ways in which AI can be used positively was indicated around radiology and other aspects of providing decision care supports, but it also has a significant risk, especially in terms of disruption in workforce, the need for certain specializations and that's why by health workers, and having that balance, especially concerns around ethics, medical legal impacts, as well as the other biases sometimes that AI will bring within the health field. So I guess thinking about the future of health workforce with digital technologies and artificial intelligence, we need to be prepared that we can use it well and not be scared of technology. So just building that digital IQ and raising that bar across the health workforce and not being fearful of it. So finally, to my last point around sustainability and sustaining the future health workforce. Improving the health workforce data is absolutely key. And just linking back to my previous slide, the study led by Professor Mabunda, which showed that basic data for health workers was not available in many countries. So not just national aggregated by age and sex is absolutely important for evidence-informed policy. National authorities should have strategic intelligence on health workforce, and the workforce projections should be made considering the population needs. So what I have over here is the data information wisdom pyramid, wherein you would use data, analyze it for information, use that information for knowledge, so that you can project into the future, have that wisdom to project in the future using that data, using that information, and having that knowledge. And finally, none of this would be possible if we don't have adequate funding. And realizing that without the right funding, we won't have the health workers, we won't have a motivated health workforce, and absolutely there is no health without health workers. So bringing it all together, just summarizing it, that the future health workforce is around training our health workers, not in those traditional forms that we know them as, but thinking about moving to the future, multidisciplinary care, having those informal pathways to work with others beyond healthcare as well. Retaining the workforce using disruptive models, but evidence-based disruptive models of care. And finally, sustaining them through sound policy, through good data and adequate funding. None of this would be possible without all of these evidence-based policies and visionary leadership. Going back to the basic building blocks, we really need them to function well to support the health workforce for better population health. I'll end on this note, but I'm very clear your thoughts, your questions, and thank you so much for listening.
Thank you very much, Prof. And we would definitely have some thoughts. I would like to open the floor for some interactions, a couple of few hands, 3 hands or so, to interact with Prof's presentation before we then move over to the next one. I can share, Prof, as we are getting a sense and hands to interact, that currently sitting with our statistics in South Africa, making use of our health resource information system and looking at the public employed staff, when it comes to our ratio for doctor-patient, if we use in a national landscape uninsured patients, using the census data of 2022, we are sitting at 4.484, which is 4.5 doctors per 10,000 population. And for the nurses, we are sitting at 13.1 in terms of the per 10,000 population. So that's based on our census 2022, minus the insured, as well as our personal or public employed doctors and nurses. Of course, it varies across provinces, and we did have a limitation when we were trying to get to that response, where at this stage we could not segregate in the provinces the insured population. So when we're calculating it per province, unfortunately, it's a bit skewed because we just used the census data without necessarily minusing the insured. because our source at the time was the report from the medical schemes, which was at this stage only national data in terms of how many people are insured. But for Eastern Cape, for instance, we're currently sitting at 3.2 per 10,000 for doctors, if we just use the population versus those that are employed by the state. And for nurses, we are sitting at 14.5 at this stage. So we have been, it's very recent, colleagues. Unfortunately, we had to respond to a parliamentary question last week. So that's why it's recent that we know that we've worked on this issue of the ratios as a National Department of Health. And I was comfortable to share because it's something that we had to submit last week in terms of a response to a portfolio parliamentary question. And we used the sources that I've mentioned to get to that. Can we see a show of hands in terms of, yes, we see 1 there, 2 there, 3 up there.
Thank you for that presentation, Professor Woodley from Nelson Mandela University. I think you mentioned some approaches that you described as being disruptive, patient-centeredness, prevention, community health systems. But these are issues that we've been talking about for decades. So is it the fact that this is disruptive, or is it really a lack of advocacy or failure of advocacy to get it implemented? And perhaps some suggestions in terms of how do we effectively advocate for implementation of these approaches? Thank you.
Thank you. We'll have a second one. We've noted 3, 4. Okay. We'll take all 4 at once, Prof, and then you can respond. Thank you.
Okay. Thank you, Prof, for that enlightening talk today. I'm Tesha Pillay. I'm the president of the Professional Association of Clinical Associates in South Africa. I think it would be important for me to mention that within the South African healthcare system now, since 2008, we've been training mid-level healthcare professionals. And one of the avenues in which this came to light is because of the health resource issues that we were having within our country. WHO mandated that within lower and middle income countries that creating this cadre, this mid-level healthcare professionals that could aid in task shifting and task sharing would really help in the struggle that we're having. And then it's quite prominent within South Africa itself. We've been struggling to roll it out effectively within the public healthcare system. Since COVID, we've had a slower retention or employment of these mid-level healthcare professionals. And I think they do play a significant role. And as part of the universities, as I can talk for Walter Sisulu, that when we recruit these students, we recruit them from these rural backgrounds with the knowledge of how rural areas is in order to be well retained within the rural healthcare system. Because that's where we typically find this retention problem significant. We can hardly retain healthcare professionals within the rural areas, yet we do have this system in place. What could be the future for mid-level healthcare professionals within the setting of looking at the challenges that we face? Thank you.
Thank you. We've got a third hand here, and then there's one up there.
No, thank you very much for the presentation, Prof. Joshi, from Public Health Department at the WSU. My interest is what you mentioned now about the issue of HRH projection in terms of the modeling. I'd be interested if you could perhaps reflect on some of the would normally.
If I may.
Sorry, I can't.
Yes, if I may represent him,
can't
he's asking
speak
for if you could comment on some of the variables that needs to be taken into account when we are doing projections on the ratios. Thank you. The last question is from the back.
Thank you, Prof. So, when you spoke about rethinking formal training for healthcare practitioners, in the same breath, you also mentioned considering measuring with other fields like engineering and technology, and in that you have also telemedicine, which measures from that. However, you also mentioned earlier that, because I believe that these advancements such as telemedicine means lesser of your physical personnel needed, but I stand to be corrected in that. However, that's a contradiction to the need that you mentioned of millions of healthcare workers needed for the UHC. How can we best reconcile that, the booming technology in healthcare in terms of telemedicine vis-a-vis the need to train more and more healthcare workers?
Thank you very much. We can hand over to you, Prof, to comment and respond to those inputs. Thank you.
Great, thanks for those questions. So the first one was around disruption. And thank you so much for asking that these models of care have been there since Alma Ata. What's the disruption over here? I hear you. I think what I was referring to, the disruption over there, was actually transforming those those community health systems. So what we had, and what we have in many countries, is community health workers who are chosen from the village, who work, do data collection, support maternal and child health and infectious diseases. Now, South Africa has done really well in upskilling community health workers to include conditions such as HIV. But still, issues like cardiovascular disease, various factors which start quite early in many of our countries, diabetes, cancer screening, kidney disease, a missed opportunity that we just focus on one part of the population. In fact, even with maternal and child health, we often miss gestational diabetes and not. Those are all missed opportunities. In terms of that disruption, it's around how do we transform this health worker to somebody who's a volunteer, who was given some basic training and then left in the community without the accountability structures in place, without upskilling the community health worker themselves, without giving them enough to function effectively, and without giving them protocols or guidelines such that they can do their work efficiently within the community, but also link back to the health system through nurses, through doctors, and have that continuity of care for patients. So when I was speaking about disruption, I was talking about how do we bring that health system down to the community and link with the community through this health worker, and also beyond this health worker. So that was the point around that. The second point around mid-level healthcare professionals, and what's the future, considering that many mid-level health professionals who were employed are not being retained. I think the concept of having mid-level health professionals was fantastic, and it still is really useful within the context, not just in low and middle income countries. I would think even in a place like Australia now, which doesn't really have community health workers. So it's quite important. But I think it's about who are these people and what is their future in terms of the health system. Of course, they'll work for some time, get completely demotivated and move out of the system. So I think it's more around what can the health system do to retain them, and we go back to those questions around retention of workforce, be it community health worker, mid-level health worker, or doctor, knowing that the doctor can easily move into a private health sector. So I guess some of the thoughts and some of the issues to discuss with policymakers is around thinking through the policies for the health worker. Are the jobs, the task sharing at the community level, is it defined? What do they, like, is there an opportunity for them to progress in their career? So I would look at more of those retention, motivation aspects of it in terms of how do we retain this workforce within the health system and see what their needs are, rather than just say that we're going to train them and you stay. But they would also need to have that career motivation of moving up, or even serving their community but skilling up so that they can do a better job. The next point was around HRH projections and modeling, variables for modeling. So there are various ways of modeling, and I can just touch upon two topics. One is the model that I presented, used by the Global Burden of Disease. What they did was they used the Universal Health Coverage Index, and those are based on the SDGs about what needs to be attained by 2030. So things around prevention, things about management and cure, vaccination. They basically broke that down and had a UHC coverage index. I'm very happy to share that paper with you if you want to read further around it. But what their assumption was that for 80% of that UHC coverage, for countries to achieve that 80%, what proportion of those would be done by doctors, by nurses, by dentists, etc. So that they broke that down, and those were the assumptions driven into that model. The other HRH projection, which many would be familiar with in the room, is the WISEN model, Workforce Indicators for Staffing Needs, which looks at different aspects of needs from the population, sees how much time is required per procedure, and then looks at, okay, what's the workforce needed in order to do X, Y, and Z within a primary health setting, within a hospital, or within a country. Again, many studies done on WISEN. It's a fantastic model, but for that model, we need some good data to then make those projections. And again, happy to link in with you and share some of the WISEN work. In fact, Professor Mabunda has done a lot of work on WISEN, and he would be, he can share some of the work that we've done there. The final point was around telemedicine, and apologies, I might just have not got that question completely right. It was around so whether we would need enough workforce if we use digital technology in telemedicine. Did I get that right?
Yes, in actual fact, it was asking the balance between producing more and yet accommodating and introducing digital space. Thank you.
All right. Thank you so much for explaining that. So I think with the digital space, the idea over there was so if we just think about somebody living in a rural region in Eastern Cape, for them to come down to a main city or a repeat visit for oncology or some chronic condition, think about them coming back and forth over and over. They will lose that day's wages, if they're daily wages. They will have a relative accompany them to the clinic. So there'll be two people whose time would be taken to visit that clinic, which actually could be a telephone consult with the same doctor. So in terms of the time required, it's actually time saving for the patient and their family. We still need that doctor or the nurse to have that consult with the patient. So in terms of the numbers, just with telemedicine, I don't think that will impact the workforce in terms of numbers. Now, when we think about AI, yes, so that does have one of the risks that we see is, would we be replaced by AI? Would university professors be replaced by AI that teaches masters or PhD students? And that's where one needs to also think about the element of human touch, the element of that empathy, that element of understanding the larger system. So the way I see it is that AI would enhance healthcare if we do it right. And that's why we need to test it out. We need to make sure we get it right, and that we don't just jump onto this latest technology, like bright and shiny technology, and use it or scale it up without making sure the checks are in place such that technology, which is evidence-based. Yes, it will have impact on the workforce, but I don't see it as a complete negative impact if we do it right. We just need to get that balance right and have the sufficient knowledge to kind of talk about what is it to get it right. Perhaps this unit can work on that aspect of human resources for health and AI. Thanks.
Thank you very much. Let's give a round of applause for the responses. And just to share in the insight that the experience we have, especially the example you made mention of oncology services, we do have patients that probably take out 3 days of their time when they have to come for services. So that's how bad it can get, and in terms of even now, the unintended consequences in terms of income loss, as well as time with the other family members. Sometimes they also leave other younger children at home. So there is that unintended consequence that also is an existing experience. It's not theoretical, it's not something that is not there, it's already existing in some of our areas. Thank you very much, and we really appreciate for the time that you've taken out, especially the insightful presentation and the engagements that you've shared with us. We've also noted that, of course, there's quite some lessons that we have to still ponder about, the issues of the type of the mid-level workers that we're talking about, and what is their trajectory in terms of the future of the healthcare system, and where would they then be impactful. And of course, the issue of ensuring that even when we are enticed, as it is the space now, when it comes to digital health, as well as also in artificial intelligence, it's a question of understanding what our system needs at this stage and how we're going to balance that, and not just jump because we are being enticed to consider certain innovations. But of course, it still does not take away that when it comes to the health workspace and the health systems platform, we would always have a room for a physical or a human being in terms of the workforce that is needed, irrespective of whether we're moving with innovation or not. So thank you very much for those lessons that we have also noted. And we are now gonna quickly move over to the next presenter before we break for tea, which we're gonna call to the fore in the form of Dr. Thomas Gadsden.
Thank you so much, Doc. Now we are going to invite in the podium with Dr. Thomas Gadsden. Doc is a research fellow at the George Institute of Global Health in Sydney, in Australia. His research focuses on health systems, health financing, and global health. He has worked in remote communities international development, policy making, and academic research. Dr. Thomas began his career as a youth worker in a remote Aboriginal community in Central Australia, working for the MT Theo program. After completing a master's in international public health, he interned at the WHO regional office in Manila for 3 months. In 2013, he was an Australian Youth Ambassador for Development in Laos. From 2014 to 2016, he was a project officer as the WSU country officer for Laos, working on a project to merge the country's disparate health insurance schemes. During this time, he completed a postgraduate certificate in health economics. From 2016 to 2019, he completed the NSW Public Health Officer Training Program at the NSW Ministry of Health. From 2019 to 2023, he completed a PhD with the George Institute of Global Health, examining the design of incentives for community health workers in East Java, Indonesia during COVID. During this period, he also worked as a data manager for a local health district during the pandemic and as a tutor for master students in the subject Skills for Working in Global Health. As a research fellow with the George Institute, Dr. Thomas is currently leading a modeled analysis of the health and cost outcomes resulting from the differential rate of stroke diagnosis by paramedics between men and women in Australia, a cost-effectiveness analysis of a public health intervention in Southeast Asia, and contributing to the feasibility study to develop a local value set for health-related quality of life studies in South Africa. Let's call now Dr. Thomas to join us in the podium. Thank you, sir.
Hi everyone. I apologize that you had to hear my entire career. Someone's been reading my LinkedIn profile. I would have sent a shorter one if I knew that was going to happen. I'm just waiting to hear if I've changed the slides myself. So, first, thank you for the opportunity to present. It's a real privilege to be here with you today. I'm going to talk about the Smart Health program in Indonesia, which is a digital health intervention developed by the George Institute. I suppose this could be framed as a kind of case study looking at an intervention to support community health workers deliver quality care. It touches on what Rahina was presenting, but is a bit more of a deep dive into this specific program. Great, thank you. So, in terms of background, I won't spend too long on the challenges facing LMICs in terms of healthcare worker shortages and NCDs. This was well covered by Rohina. But just quickly, these graphs show the unequal burden of NCDs in low and middle income countries, the poorer access to care, to care and quality care, the poorer access to workforce, and limited access to affordable medicines in LMICs. Thank you. And so, as we heard, community health workers have the potential to play a really important role in strengthening the delivery of care at the primary healthcare level on the front lines. And I like to show this photo when I'm talking about community health workers. I guess the WHO definition of a community health worker is reasonably arbitrary. There's several different definitions reflecting the many different types of community health workers globally. The WHO definition is that they typically have less than 2 years of training, that they're part of the community that they serve, so they live in the community that they serve, that they're not professionals, but they have received some limited training. Maybe I'll just say next slide.
Okay.
Yeah. Back, please. Yeah, great. So this reflects the many different types of community health worker programs that are out there. There's a huge variety. Some receive up to 2 years of training, some receive a few hours of training. And these varies depending on whether it's a government-supported program, and often we have very small community health worker programs as well, which are just supported by different NGOs to work on specific diseases. So there can be quite a lot of fragmentation even within one country. I'd like to show this photo because I think it exemplifies the WHO definition of community health workers. This was taken by me in a remote province in Laos, and it shows the woman in the yellow shirt who's a part of the Hmong community, which is an ethnic minority in the Southeast Asia region, convincing the other woman, who's also part of the Hmong community, to receive a polio vaccination from the 2 male healthcare workers there. So I think it really exemplifies the importance of community health workers in extending the formal healthcare system to often vulnerable populations and locations, and while also building trust in the system. Next slide, please. So to support community health workers, as Rohina mentioned, there's been huge growth in the use of digital health technologies. And this covers a huge range of health issues from communicable to non-communicable to mental health to maternal and child health, and can be used, has been tested in a range of modalities, I suppose, most often in the form of mobile phones or in a tablet. As Rohina mentioned, there's many benefits that come from this technology. So it's typically low cost, and it can support community health workers to accurately diagnose and treat diseases. It also has the benefit of really supporting them to collect robust data that can be sent for monitoring purposes quickly. Next slide, please. So the program that I'm going to talk about today a bit more in depth is the Smart Health program. So Smart Health is the name of the model of care, and it's also the program that is based on a tablet as an application for community health workers to use. So the way it works is that the community health workers have this tablet with the application that they use to screen their the community members. It includes an inbuilt algorithm that, based on the data they collect, it determines their risk of cardiovascular disease. So that helps the community health worker decide whether they need to refer the patient to the primary healthcare centre for treatment. The application is also used at the primary healthcare centre by doctors and nurses in the form of what's known as a clinical decision support system, where essentially that supports them to decide which medication is appropriate to prescribe to the patient. The information, the treatment plan put in by the doctors and nurses is then automatically shared with the community health worker so that they can monitor the patient in the community and ensuring treatment adherence. So it's a whole model of care that's connecting the community health worker with the primary healthcare system and integrating the service delivery for the patient. Next slide, please. So the intervention was quite well suited to Indonesia. due to the kind of prevalence of cardiovascular disease, estimated to cause 1/3 of deaths in 2016, and with a high proportion of those patients not receiving preventive care. On the other hand, there was also a very strong community health worker program that already existed in Indonesia. Indonesia has one of the largest and longest running community health worker programs globally. So that workforce existed, which could be leveraged to deliver this program. Touching a little bit on the community health worker retention and motivation in Indonesia, it's quite a unique case, I think, in that the community health workers are village health volunteers. They receive a small stipend, but it's essentially a symbolic reward for contributing to their village. The program also really benefits from the cultural value that's attached from giving back to one's community. So there's a whole value, I suppose, that in Indonesia about supporting your community, and that kind of enhances the motivation to become a community health worker because it's seen as, it's recognized as bringing value. So, yeah, there were supportive conditions for this program. In collaboration with the district government, 8 villages were identified to deliver the intervention, with the outcome being the proportion using appropriate preventive medications at follow-up. And this was just tested in a pragmatic trial over 12 months. Thank you. So, as we can see from this slide, it had really positive results. It improved the quality of care, patient outcomes, and it was also found to be cost-effective. The results on the left of that table show that in the intervention villages, the proportion on appropriate treatment increased quite a lot. The proportion taking blood pressure medication also increased a lot, leading to reductions in blood pressure amongst the community members. So this was great, really positive findings, and the district government adopted the program to be scaled up across the district, which is a really great outcome. So it was they made a sizable financial commitment to taking on board implementation across the district to more than 390 villages and more than 1 million population. Thank you. But obviously, scaling up brings more challenges than just testing the intervention in 8 villages. So to do this carefully, a whole framework was developed around ensuring that implementation was contextually based so that the program could be adapted to local conditions before expanding more and more to different villages. So the model for this was based on something called a Plan, Do, Study, Act, a PDSA cycle, which is a model of care, a framework typically used to improve quality of care. And there were 3 of these cycles, and you can see at the bottom the weeks, so it ran over 10 weeks each cycle. And the purpose of this is to kind of iteratively implement the intervention while taking on board potential barriers, adapting the intervention based on change strategies which are developed through a team, testing those strategies on a small scale, and then again monitoring implementation and continuing with the cycle. And that's represented by the graph here. So we have the implementation in the bigger box with data collection, ongoing, quantitative and qualitative, implementation barriers identified, and then change strategies identified through working groups, including key stakeholders, and then used to inform the next round of implementation so that it can really be tested and adapted to the local context on a small scale before going to a bigger scale. Thank you. So, unfortunately, this coincided with the COVID-19 pandemic, so there were major disruptions to implementation. This slide shows some of the barriers that were identified and the change strategies used to try to address them. COVID-19 obviously being a big one, really disrupted delivery of care. One of the adaptations was to centralize screening so that people come to a centralized location rather than doing door-to-door screening. Several other smaller barriers identified, such as refresher training required for the community health workers, additional equipment needed. What else did we have here? New tablets required, a bit of targeted screening required, so targeting males where it was found to have low rates of participation. One of the key barriers that we found, though, was challenges with the application itself. So there were very slow loading times and malfunctions, which I don't think were as problematic in the trial, but became a real issue in the test of scale up in 10 villages at the start. As well as integrating the data collected with the electronic health system at the primary healthcare system level. So making sure that the data collected by community health workers was received and integrated into the primary healthcare level data system, which wasn't achieved, so it was a big barrier for implementation. Next slide, please. So I just show this here. This is the number of community members screened in each of the 3 cycles by village, 10 villages at the start of this test of scale up, so a small scale test. And we can see that the implementation ran as planned in the first cycle. Second cycle was really hit hard by COVID with a lot of lockdowns in villages, so only a couple managed to do some screening. And then cycle 3 really got away from the 10-week implementation. It was extended to more than a year to try and work out those issues with the application, the malfunctions, as well as integrating the data with the primary healthcare system electronic information system. Yep. Next slide, please. So, evaluation of the scale-up is continuing. It's expanding beyond those 10 original tested scale-up villages. But it's taught some really good lessons about the challenges of taking something that was implemented on a reasonably small scale in a pragmatic fashion, but expanding that to adapt to local context comes with many more challenges. And these are some of the lessons that the integration with existing electronic informations is absolutely critical, and it's been fundamental to have a dedicated IT team to support that process. But it's also been really positive to see that there has been a high level of government buy-in throughout the test of scale-up. So, and we could say that's reflected by the amount of change strategies that were tested to refine implementation over the period. And that's come with financial commitment as well. So I've talked just about the Smart Health program in Indonesia, but it has been tested in other countries and is undergoing testing or moves to implement it in other countries, working on a range of different health issues. So some of these other countries here are India, China, Thailand, Sri Lanka, covering different issues from cardiovascular risk assessment in Indonesia to diabetes, mental health, and HIV. And I'll just finish on this slide. It's some of the key messages that have emerged from the broader program of work about the potential of Smart Health to support community health workers deliver quality of care at the front lines. Thank you very much.
Thank you so much to have. Thank you so much to have an audience who's so much participative. Whenever somebody is done talking, there's a round of applause, not being asking me to do it, but you just automatically do that. Thank you so much for that. Now, Dr. Thomas, while he was presenting here, he was presenting a study which was done in Indonesia. And the study was about use of screening and decision support app to support village health workers, village health volunteers. Now he has stated very well that the app has been tested in many countries and it is working. And the app, I think, also can work for us here in South Africa. If it is going to be implemented, so that the screening of the clients is done in the communities where the doctors and the nurses are working, for example, in the primary care facilities. Then if the screening is done there in time, the clients will be diagnosed in time and be assisted and be helped in time before the complications can be there. Then on that note, if there's any person with questions for Dr. Thomas, I'm showing to the audience. Whether the young men will assist us with the roving mic? Thanks. Any questions?
Can you please see a show of hands? Oh, there's one at the front, there's one at the back, there's one. All right, thank you.
No, thank you, Chair. Percy Mashat. Mine is not a question, but a comment. Maybe the colleagues here in the country can actually say how we overcome it. I don't think the program software would be a challenge. The challenge is the competing software programs we have in the country. Each one coming with this, each one coming with that, and the various gadgets. I'm not sure whether you've had that challenge, where you and how you overcame that, because we do have, but the problem is that they are not using the same baseline, for instance. So if you could just comment on that, thank you.
Yes, that's a great point. I didn't touch on it when I was just briefly mentioning digital health with community health workers, but it has it's exploded the amount of applications that there are for community health workers to work on this problem, on that problem, and it could be detrimental to the point that it's overburdening the community health workers to deliver their main role. So I know in Indonesia they have this problem. There's over 400 apps I think have been developed just by different government alone, and I know they have developed or established a team to work on synthesizing them into a smaller number that's more manageable, to have some coordination, some high-level coordination around this issue. In terms of whether it was an issue in this case with the smart health application in Indonesia, I know there were ongoing discussions around other applications that existed and kind of a little bit of a competitive environment in terms of which one is going to win out. The one, in this case, we had the issues that I mentioned with the application about loading and malfunction and integration with the existing electronic information system, and that spurred on the development of a government app broadly based on smart health to do the same thing to complement this one. So, yes.
Thank you, Doc, for the presentation. I was actually impressed with the presentation of the Smart Health program because you mentioned that in the program you guys pick out people from the area that you are taking the Smart Health digital marketing in. So it will be helpful here in South Africa because if we could go to clinics and actually take people from the community, it would really help because some of us as youth or young people are actually unemployed. So getting to know and being innovative in technology and learning this digital marketing would really be helpful to our youth. Thank you.
No, thanks, Doc. I'm the KKN. My question was partially covered by Dr. Malato when he asked more on the current existing gadgets in terms of conflicting of gadgets. But mine is more on the data integrity, which of course you touched base on the issue of the relevance and the significance of the very same app. I'm more interested to know which data reconciliation tool do you actually focus on when you were hitting the ground in terms of collecting data, the very same stuff that we're embarking on. Thank you very much.
Sorry, I'm not sure I understood the question. Focus on collecting.
Remember, in terms of the data integrity, our focus is more on timeless, correctness, and then its commitment. So I wanted to know if ever there was a specific data reconciliation tool that you actually did in terms of comprehensively coming up with the output.
I'm not quite sure, to be honest. You've stumped me a bit on that one. No, I might have to get back to you on that one, sorry. Apologies, we can talk about that. Yeah, sure.
Any other questions, colleagues? I can see no hands. Let's again give Dr. Palmer a round of applause. Thanks so much. Now I think we have reached at the time where we must have our tea, and our tea is served behind us. And our tea will be only 15 minutes from now. Then when we come back, we continue our program. Can we quickly grab our tea and have it? Thank you so much.
Thank you very much. And we are told those that might have gone through the other side room in the morning, they can go there to verify their details as we go for tea. I got difference. Something. Thank you very much, colleagues. We will see you in 15 minutes time. Thank you.
to start again. At this moment, we are going to call upon our presenter who is online. The presenter is Dr. Blake Angel, is a health economist holding a position as program lead. Health Workforce Economics in the Center for Health Systems Science at the George Institute for Global Health, and co-joint senior lecturer at UNSW Sydney. He is an NHMRC Emerging Leadership Fellow with expertise in health economic evaluation, health systems, research, and discrete choice experiments. Dr. Blake's research examines the better use of economics in health policy, specifically focusing on vulnerable populations around the world. He has health policy experience, having previously held positions at the NSW Agency for Clinical Innovation, senior economist from 2013 to 2017, and the NSW Treasury policy analyst from 2011 to 2013. He is currently based in London. He currently serves as an economist expert on the evaluation of subcommittee of the Medical Services Advisory Committee, providing economic advice on funding applications to Medicare. Dr. Blake is involved in a number of international collaborations. He worked on the core teams of Lancet Nigeria Commission and is the lead technical advisor in discrete choice experiments for the health stream of research under the Anti-Corruption Evidence Consortium funded by UK Aid. Dr. Blake now is going to deliberate on building a healthier future, the need for strategic investments in the health workforce. Over to you, Dr. Blake, online. Thank you. You can unmute, Doc. Dr. Blake, can you hear us? I think there's a challenge network there. Dr. Blake? I think there's a challenge network with Dr. Blake. Yeah. Thank you.
Thank you so much for that introduction. Just check you guys can see that right. No problem, thank you. So can the main room hear me now?
Yes, they can hear you.
Sorry. Okay, I'll get started then. Yes, I'm sorry not to be there, but very happy to connect virtually. I've had the pleasure of working with Professor Sigambuzu for a number of years, alongside a few others in the team over there, and very excited about the potential of this new centre. I hope we can continue to build strong collaborations and achieve some ambitious goals. So today I've been asked to reflect on some of my work examining the economic issues affecting health workers globally, and also noting the presence of many much more esteemed thinkers than me in this area. I hope to highlight a couple of areas that I see potential for future work and hopefully some ongoing collaboration for all of us going forward. We've heard a lot already about health workers, so I'll keep my background very brief and just focus on a few key and probably self-evident points. The first, I think, almost preemptively quotes Professor Joshi from this morning. Health systems are a lot more than just health workers, but without the health workers, there isn't much of a health system. The second point is that globally there's extensive resources invested in health workers. Estimates range from around 40 to 50% of total health expenditure is devoted to health workers and their salaries. And on top of that is the training and as we heard this morning, often their replacement and retraining. The final point is probably the crux of a lot of my work, which is that a lot of this investment does not seem to directly align with the goals of maximising population health or other health system objectives. There's a lot of examples of this, and I suspect everyone in the room and online could think of a couple. But I wanted to just draw on this idea and bring out some of the work that we have been doing, particularly around two areas, which are this idea, I think, that there's insufficient economic evidence guiding investment into programs that are led by perhaps non-doctor health workers, such as community health workers, as we heard from Tom and Rahina earlier. And I guess using economic evidence on that advocacy side that we discussed this morning to sort of generate a case for investment in those programs. On top of that, I think there's some shortcomings in policy that restricts the effectiveness of respond to complex problems that I think has led to decades of investment in programs that have minimal or at least unclear impact. And I'll give a couple of examples of work we've done in that regard. So under this first point, I think probably the key point is to just this idea that there's a variety of health workers. And I think health systems of all incomes need to ensure that they're making the most out of the available workforce that they do have. Investments often biased, I think, towards doctor-led later stage care and interventions. I think often at the expense of more cost-effective alternatives. This picture on the right is some modelling that I did based in Nigeria, and it's looking at maternal and child health outcomes across the country over the next 10 years. I won't go into the details, but basically these bars show the numbers of deaths that could be avoided. So in other words, the numbers of lives saved. And so over the 10 years, there was up to 4 million mothers and kids, basically, deaths that could be averted through a package of quite simple interventions. And 95% of the workforce that we modelled needed to deliver these interventions are non-doctors. So they were community health workers, nurses, midwives, and others along those lines. But investment, the available resources in Nigeria that are being spent on healthcare tend to be dramatically aimed at doctors still and later stage care. So we have sort of a few studies in this area. A lot of it is around economic evaluations. What an economic evaluation essentially is, for those in the room who might not be familiar. Basically, they try and determine the relative costs and benefits of investment in different policy options. So to work out which policy or intervention is the best to invest in, we basically just compare the different outcomes and try and convert this down to a comparable level. As a whole, these economic evaluations tend to demonstrate that when, in many situations, that when properly supported and supervised, many interventions led by non-physicians or similarly non-specialist doctors can be cost-effective alternatives to normal care, to doctor-led care, sorry, fill service or personnel gaps and even better meet patient needs. And just to note that this has been found across countries of all different income levels. So one example is just building on the results that Tom was speaking about this morning. I won't go into the detail, but this is the cost effectiveness analysis results for the initial trial that Tom went into this morning about the smart health intervention. As he mentioned, we found the intervention to be highly cost effective relative to usual care patterns, according to usual thresholds and usual measures of cost effectiveness, and considering Indonesia's relative income. So this evidence, I think, was an important part of the this economic results was an important part of the evidence base that sort of led to that next stage of local investment and the scale up project that's still going on and that Tom went through this morning. So community health worker programs, as Rahina mentioned, are far more common in low and middle income countries, but I guess the course to appropriately manage different types of care is an issue that affects countries of all income levels. So, for example, in Australia, we've done a number of studies, and this is one example. Again, I don't have time to go into the details, but this was an example where the care for chronic eye diseases, glaucoma and diabetic retinopathy, it's usually managed by an ophthalmologist, so a specialist within a hospital. The accessing care was a huge problem. There were wait lists of over a year to get an appointment. The intervention transferred a lot of the routine monitoring and care provision to rather than ophthalmologists. And so what we found were dramatically reduced wait times, as you can probably imagine, better attendance of patients, and also quite significant cost savings for each person. So the point here is just to point out that it is a universal issue affecting countries of all income levels. The next part of research I'd like to go into is this idea that cost effectiveness is great, and building an economic evidence base to support investment in these cost effective models of care is an important tool to guide health investments. But there are a range of system issues, as you all know, that can undermine healthcare access, quality, and effectiveness. So some of these issues that we've been looking at include health system corruption, as Rahina mentioned, the motivation, retention, and training of health workers, as well as the incentives facing health workers because of different financing models. All of these things can have significant impacts on the care that is ultimately accessed and provided to the population. This example, this picture on the right, sorry, is an example of what we call a discrete choice experiment, which is a technique that we have used quite often. This piece of work was actually also led by Tom, presented this morning. What a discrete choice experiment does is, in situations where a trial isn't possible, we try and replicate the types of factors that are driving behaviour, the types of decisions being made by people, in this case health workers, using a survey and asked them to respond to a series of questions like these, where in this case they were asked to pick between two potential jobs, and the jobs differ on the basis of key attributes that we've established are the main drivers of behaviour. So we've used this technique quite a lot, in particular to look at both the motivation and retention of most important factors that community health workers and others see in their job, but we've also, as well as using it in the corruption space, which I will provide a couple of examples of now. So health worker corruption is sort of an issue that's been seen as essentially unsolvable for many years. There's a long history of attempted interventions that have had essentially little or no impact in a lot of settings. Corruption affects health systems across all income levels and incorporates a range of behaviours, including of health workers, which includes things such as informal payments, where patients are charged additional fees, or fees for care that should be provided free of charge at the point of care, and health worker absenteeism, where health workers are paid to be at work but aren't, essentially. So traditionally, health worker corruption has been seen through this moral lens, where it's sort of a moral failing that it's some sort of deficiency in the health worker, where they're taking advantage of a system. And so the fixes for this have been traditionally more stringent and harsher penalties for infractions. Our findings and also the history of ineffective interventions over recent decades suggests that the story is a bit more complicated than this. And actually, many of the drivers of corrupt behaviours are things that probably most or many people will consider to be quite reasonable reasons, explanations for missing work, for example. So under program of research, we've undertaken several studies in Nigeria, Tanzania, and Bangladesh, with a couple of further countries being studied now. And what we were looking to do is basically identify the key drivers of these corrupt behaviours and see whether there was any space to potentially intervene to realign the incentives that are driving these behaviours, better align it with health system goals, such as provision of health care. Across all these studies, there are a few general findings that we can pull out. Corruption, specifically in this case, informal payments and absenteeism, was very common across the study countries. In each country, there were groups of people who could deliberately break the rules and escape sanction. So that this is sort of the traditional view of corruption. There definitely were people that were taking advantage of the system. There were also a large proportion of infractions were just related to context-specific issues. Our argument is basically if these issues could be addressed, it's probably a good path to payments as a means to actually fund the care in situations where care wasn't properly funded, or payment was delayed, or even supplies weren't able to be paid for, so informal payments were then levied. Or if people weren't able, there were no supplies at work, so there was sort of no point going to work, or there were huge rates of violence and abuse facing health workers, which sort of led to people staying away from work. the local networks of health workers were strong drivers of behaviour, and that this sort of worked in two ways. In some ways, it facilitated corruption in that people could get away with breaking the rules without fear of punishment. But also in areas where there were strong connections with local policymakers, there was lower corruption, and the impact of local monitoring seemed to be much greater than a higher level monitoring and punishments. So our proposal was basically to address, if we could address these,
Okay, we can see that Dr. Blake has a challenge with the internet. Or is us? Oh, sorry, Doc, it's us. Slow shedding, ne? Okay. At the moment that with Dr. Blake,
most susceptible to intervention. Maybe if I stop sharing, it'll
be better. The mic has been muted.
Can you hear me now?
Yes, yes, I can hear you. Thank you.
Okay, I'm almost done. So hopefully it works. I guess the key point here is that a lot of our data suggests that simply better supporting health workers will result in improvements, as you might expect, in reductions. I get in corrupt behaviours, and also that there is different impacts of the project that and allow people that are willing a bit of flexibility in that. These results are very similar to a series of studies we've conducted, predominantly with Rahina, who presented some of the results about they had very similar findings of widespread poor working conditions facing these workers, but in this case, it's sort of resulting in high levels of turnover and low motivation for the health workers themselves. So the specific results varied across the study countries, but I guess the opportunities for career growth, which I know Rahina spoke about this morning, was hugely valued across most of the samples. Salary was
we're having a challenge, Doc, with the network. with the challenge of the network, with Dr. Blake, with us, can we, when he is online again, can we ask him to give a chance to the other speakers, then after them, if the network is okay, he can continue. Do we agree with that? Do we agree? Yes, we can ask him when he's online to when he's back.
But it's sometimes
Doc? Dr. Blake? Okay. We can continue with the
most
speakers online.
important
Doc, we're having a challenge.
relative to
Doc, Dr. Blake, we're having a challenge with the network. Can you please, at the moment, wait for us, for the speakers here in the room, to continue?
Opportunity to sort of build a career and
did you hear me, Doc?
see a future career out of the jobs.
It's freezed.
So just finally,
That's
I'll look at it. Can you hear me still?
Dr. Blake, there's a challenge with the network. Can you please, at the moment, wait for us, for the presenters in the room to share their topics? Then after them, you can talk again, please. Okay, good talk. Now, we are going to shift. Okay. Let's now continue with our speakers because of the challenge of the network. Now, we have changed a little bit
Can
for
you
the
hear me?
presentations. Unmute, please, sir. Unmute him. Huh? He's going to write on the charts. Please write for us on the chat. Okay. At the moment now, we have shifted a little bit with the presentations. Dr. Blake will continue after the three ones in the room now. After the second speaker is going to sit on the orange couch, wait for the time of the questions, and the third and the second and the fourth one. Then after the fourth speaker has deliberated, we'll take the questions. The question will be shorter, not allowing everybody maybe not to ask the questions, but we will ask the questions after the first speaker. Now we are going to call upon Professor Stephen John. Okay, with his bio. Professor Stephen John is the co-director of the Health Systems Program at the George Institute for Global Health, conjoint professor of health economics at the University of NSW, and professor of health systems at the Imperial College in London. He is an honorary professor at the University of Sydney, a director of the Sachs Institute, and an associate at both the Menzies Center for Health Policy and Poche Center for the Indigenous Health. He is a current equivalent of the SAMRC Principal Research Fellow and has previously held posts at the London School of Hygiene and Tropical Medicine and the Center for Health Economics Research and Evaluation in Sydney. Prof. John has over 20 years of experience in health economics, and he has published over 200 scientific articles and authored 2 textbooks in the health economics. He has worked closely with various governments of different levels, both in Australia, Commonwealth and state, and overseas, with international agencies such as WHO and industry. His areas of expertise are economic evaluation, health financing, health sector priority setting, indigenous and global health issues, and the economics of chronic diseases. His areas of expertise also are economic evaluation, health financing, indigenous and global health issues. He is also a member of the Lancet Task Force on Non-Communicable Diseases and Economics. He has worked with governments, both in Australia and overseas, and with the international agencies such as the WHO and industry. He has a strong interest in training and organizational capacity building in the health technology assessment, and has been involved in the projects in China and India to investigate the translation of HTA evidence into government decision making. And at the moment, Professor Stephen John will be talking to us about universal health coverage, financial protection, and cancer care. Over to Prof. To the podium. Thank you.
Thanks for the introduction, and firstly, very grateful for the invitation to come here and to meet you all and to be part of this launch. It's a very exciting initiative and really grateful to have the opportunity to speak to you. So the presentation today, I'm going to take a slight sort of deviation from the theme. I will talk about some of the work that we're planning around community health workers, particularly in South Africa, and it's a project that we're hoping to get funded around the use of community health workers in cancer care. I'll talk about that at the second half of this presentation, but in the first half, I want to sort of focus a bit more on aspects of universal health coverage that we've been doing quite a bit of research on in the last few years through my team. As you heard in the introduction, a lot of my work revolves around health economics and health financing. And we've done a number of studies that examined the impact of non-communicable diseases on patients in terms of their out-of-pocket costs and catastrophic expenditure. And in the last few years, we've also been looking to do some more work in this area in South Africa and Africa in general. So I'd be keen to hear your thoughts about some of the work that we've done in the past in this space. So I feel this is an opportunity to maybe present some of the work more broadly that we do and open up discussion about potential ways in which we can collaborate further in future. So that's my topic's a fairly broad one. It's around universal health coverage and cancer care. So just a bit of some introductory comments about this work that we've done in the last few years. So you've probably come across this definition before, what universal health coverage is. This comes from the WHO. It means that all people have access to the full range of quality health services they need, when and where they need them, without financial hardship. And obviously, a big part of that definition is the economic side, the fact that people shouldn't be facing major financial burdens and barriers when they're accessing care. And I understand in South Africa, we're in the process of instituting national health insurance as a way of trying to address this problem. This particular statistics is a little old, but it's hasn't been updated, but it just gives you a sense of the scale of the problem. So about 100 million people a year are pushed into poverty as a result of illness. And about 150 million per year experience financial catastrophe. So that means a level of expenditure that is defined as catastrophic for the household. And I'll talk a little bit more about that definition a bit later on, but that's a sense of the burden. In South Africa, out-of-pocket expenditure as a percentage of health expenditure is 5%. So that's down from 15% since 2000. So you're doing well in terms of out-of-pocket burden. And hopefully you're going to do better with universal health coverage, national health insurance coming in. That's the plan, but what we found in the past that health insurance isn't the only fix for financial protection, and sometimes health insurance can actually increase costs, and we can talk about that later in the discussion. But hopefully in the next few years you'll experience a further improvement in that statistic. I was just trying to look for more information in South Africa. Illness-induced poverty from out-of-pocket expenditure is less than 1% of the population per year. It comes from a study from Koch and Getso in 2020. So again, that's promising, and that's a lot better than many other countries. The incidence of catastrophic expenditure from cancer care, and as you can imagine, the expenditure on cancer care can potentially really skyrocket, particularly once people get into advanced stages of treatment. 47% in middle-income countries, and astonishingly 74% in low-income countries. So that means 75% of people who get cancer in low-income countries experience financial catastrophe. So that's a huge, huge problem in terms of universal health coverage. So against that background, we did a study a few years ago, and it was in Asia. And as I said, it's something that we want to sort of try to replicate in Africa. Financial catastrophe, treatment discontinuation and death associated with surgically operable cancer in Southeast Asia. It's called the ACTION study. And the aim of the study was to determine the economic burden on households in Southeast Asia associated with the first-time diagnosis of cancer. So this was a large study of about 9,000 patients, but this particular paper that I'm reporting here was a sub-study of those patients who were indicated for surgery. So this cohort of 4,584 consecutive adult patients with a first-time diagnosis of cancer, and who, as I said, were indicated for surgery. The 47 hospitals, and we did interviews at baseline at 3 months. And the outcomes that we're looking at 3 months were, so there were 4 potential outcomes you could achieve at the end of 3 months. Firstly, you could be hospitalised with financial catastrophe. So that's obviously a bad outcome. So you get treatment, you get hospitalised, and you experience out-of-pocket costs which are greater than 30% of your annual household income. You can be hospitalised but experience no financial catastrophe, so that's ideal. That's the best outcome because you had surgery, you've been hospitalised for that surgery, but you haven't experienced financial catastrophe. You can experience no hospitalisation. In other words, you've discontinued treatment. Surgery is indicated on your plan, but you've not even proceeded with treatment, and to a large extent that would have been attributable to the financial barriers, or you could have died. And there were 4 outcomes we were looking at. And I won't go into too much in the methods, I'll just give you the results. So 31% of participants incurred financial catastrophe. So a third of patients experienced costs that exceeded 30% of their income. 8% had died, 23% discontinued treatment, and 38% continued treatment and avoided financial catastrophe. So from what you can see, only 38% achieved what we would consider a good outcome. Some of the details around those results. So women had a higher risk of financial catastrophe than men. Health insurance, not surprisingly, was significantly associated with a lower risk of treatment discontinuation. High income had a lower risk of death, lower risk of financial catastrophe, treatment discontinuation, and financial catastrophe. Not surprising. Higher income, the better off you're going to be in terms of outcome. Lower education, not being in paid work, experience of economic hardship at baseline were generally associated with higher risk of death and treatment discontinuation. So again, not too surprising. The worse you were in terms of education, the worse the outcomes were likely to be. So in conclusion from that study, health insurance coverage protects from financial catastrophe and encourages continuation with treatment. So not surprising there. Cancer and the need for surgery. result in a many-fold elevation in the risk of financial catastrophe versus general populations in Southeast Asia. Women are particularly vulnerable to financial catastrophe associated with cancer, and so efforts are needed to offset the costs of treating female cancers in particular. And socio-economic disadvantage are most likely to incur adverse outcomes, and that would reinforce a spiral where, you know, economic disadvantage, we know, predisposes you to a greater risk of illness, which in turn predisposes you to a greater risk of economic disadvantage, which then perpetuates a potential cycle. So the findings from this study, it was an observational study, it was done in 8 countries, and we published it. One of the, I suppose, very positive outcomes was that it attracted a lot of attention. And in particular, in the Philippines, where the study was done. And at the time, the Philippine Senate was considering the implementation of what was called the National Integrated Cancer Act, which was going to establish a national program of cancer control, and was going to provide financial coverage, so reduction in out-of-pocket costs for people seeking cancer. And a debate over this act, Senator Angara cited the findings of the study as support for this this new act. And eventually the act was put in place, and we've recently, I haven't reported here, but we've recently continued our collaborations with colleagues in the Philippines to try to evaluate some of the programs that have emerged as a result of the act. And as you can see here, this research potentially develops into a longer term relationship where we can track the possible impact of a study on policy, and then see how that unfolds over a number of years. So, look, I was thinking a bit about sort of the implications of this study and the work that we might be doing through the centre with colleagues such as Sikumbuzo. And, you know, what impact do out-of-pocket costs have on treatment decisions? And I wanted to sort of see what the literature says in an African context. And to be honest, there isn't much literature. And so one of the, as you saw in this study, the impact of out-of-pocket costs isn't just in relation to economic hardship experienced by families. It also impacts on people's treatment decisions. And sometimes you may find that once you have high out-of-pocket costs with treatment, that conversely, you may actually see low levels of economic hardship, largely because people are deterred from going to treatment, so they're not incurring those costs in the first place. So what we need to look at is not just the incidence of financial catastrophe and poverty associated with treatment, but we also need to look at the impact on treatment decisions, and that can manifest in things such as the failure to initiate treatment, treatment abandonment, non-adherence. And 2 studies I found which looked at this in the African context. One study in sub-Saharan Africa looked at childhood cancer abandonment rates, found that they were 7%, much higher in Ethiopia. 34% of childhood cancers resulted in abandonment of treatment. And this was a question that we looked at more broadly when we did a global systematic review of treatment abandonment for childhood cancer. So this is a problem where families, when they have a child who's been diagnosed with cancer and they face the prospect of treatment and the potential out-of-pocket costs of that treatment, and we wanted to look at what were the rates of treatment abandonment for childhood cancers. And in particular, what we wanted to see was whether there were any differences by sex. So whether girls experience a higher abandonment rate than boys. Essentially, that was our hypothesis. And you can see why that might occur because of gender norms in certain places where maybe a higher value might be attached to the life of a male son a child as opposed to a female child, and it's a question that we wanted to explore in this particular review. We did a systematic review, a meta-analysis, and happily we found, I won't bore you with all that text, I'll just give you the results from. We found pretty much no difference between males and females in terms of treatment abandonment rates. The only thing that we didn't account for when we planned the study was in some settings there was a difference, and in particular in India. There were 4 studies that were done in India which did show a pro-boy, pro-male bias in terms of abandonment rates. But generally speaking, across the rest of the studies, there was no difference in abandonment. So that's abandonment. We've also done some advocacy work through the Lancet Commission that we on NCDs and economics, and part of that was a review that looked at internationally the burden of NCDs on households in terms of catastrophic expenditure. And we found from the studies that were available that households who are not insured, that means national insurance or private insurance, had no level of insurance, associated with 2 to 7-fold higher odds of experience catastrophic costs associated with out-of-pocket expenditure. Protection was often offered by health insurance, but it was often incomplete. So you often found people, even with health insurance, experience catastrophic expenditure. Health insurance alone isn't a panacea, because often health insurance coverage has gaps, has deductibles, has co-payments, has gaps in the benefit package, and people can slip through these gaps and still experience high costs. To enable the coverage of chronic costs associated with NCDs. So NCDs basically are chronic conditions. And by that I mean that they're sort of long-term, they're predictable, and providing health insurance coverage for chronic conditions is a different proposition to covering infectious diseases where there's an acute phase and then people recover. Chronic conditions mean lifetime costs, and for an insurer, that's a very difficult proposition. And particularly for private insurance, they'll often find ways in which to avoid covering people with chronic conditions, because it's a surefire loss leader. If you're providing financial protection with somebody who's on renal dialysis, for instance, as an insurer, all you're doing is paying costs. There's no risk associated with it. You're just going to make loss. So in a commercial market, insurance for non-communicable diseases is often non-commercially viable. And so what we argue in the Lancet Task Force on NCDs and economics is that if we're looking at providing financial protection for people, particularly when we're talking about the burden of NCDs, we're going to have to look at schemes that involve compulsory enrolment or finance through taxation. In other words, publicly funded national schemes, rather than relying on private insurance. So that's just a bit of background to some of the broader work that we've been doing around universal health coverage and out-of-pocket costs. And as I said, we want really be keen to see if we can do some similar work through the centre in South Africa and Africa. Here's a piece of work that we have firm plans to do, and which we put in a proposal last year to the NIHR, which is a UK funding agency, to look at community and frontline health workers in the prevention and management of women's cancer in South Africa. It's called Confront Cancer. So it's a partnership between Walter Sisulu University, Imperial College, University of New South Wales in Australia, and community and frontline health workers in rural Eastern Cape and Mpumalanga provinces in South Africa. So the idea is to co-develop locally relevant programs to improve knowledge, increase screening for breast and cervical cancer, and support women in accessing follow-up care. And so the rationale and background for this study. So these are statistics, again, probably not surprising to you. 2018, cervical cancer resulted in 5,600 deaths in South Africa and 4,700 deaths for breast cancer. 2017, South African government introduced a national strategy aimed at early detection for screening, referral and treatment. It also recently introduced the national insurance system to facilitate access to care. So all these things are highlighting positive sort of policy intent in terms of improving access to these treatment for these cancers. However, there are a number of barriers to success here. So they include poor health literacy, cancer stigma, delays in screening, referral, diagnosis and treatment, poor coordination of services, shortage of skilled health professionals, financial and logistical barriers. So in terms of some of the work that's been done previously in this area, so there were 2 studies in 2023 that found that hospital and primary care nurses lack knowledge on cervical cancer and an understanding of its importance. At the same time, the WHO recommends screening for cervical cancer as well as for breast cancer in low resource settings. So these, these have been shown to be cost effective and can be performed by community health workers. So despite the existence of national strategies for community screening of cancers, the uptake of these programs has been poor, particularly in rural regions. So the aim of this study was to, as I said, co-develop a community education and frontline worker training program to improve cervical and breast cancer screening. And associated with that, referrals in communities in South Africa, so not just screening, but improving referral channels to care. And to evaluate the effectiveness, cost effectiveness and implementation of this program. So the specific objectives of this study would be to co-develop and adapt the intervention, to understand the barriers and facilitators of implementation, to then implement it through a cluster randomised controlled trial and evaluate its effectiveness, and then evaluate its cost effectiveness. So so the methods that we would use, so it would be a cluster randomised of a trial of a educational intervention for frontline health workers in the 2 provinces. The participants would be frontline health workers and women in the 30 to 65 year age group. And there'd be a following baseline survey of villages in South Africa, which will be then randomised to the intervention and control arm. So, as I said, inclusion criteria 30 to 65, exclusion criteria prior history of cancer of the cervix or breast, or those who were screened in the past 5 years. And the control group would be the usual care, so no further interaction. So the primary outcome that we would be interested in, once we've randomised and run the intervention and compared between the 2 groups, would be the proportion of women eligible for screening who were screened for cervical cancer or breast cancer since baseline. So we're hoping to see improvement in screening rate, which is an obvious primary outcome. Secondary outcome would be proportion of women who were screened just for cervical cancer. The other secondary would just be for breast cancer. Then we'd also be looking at knowledge of cancer, and knowledge of cancer in the community, so knowledge amongst women in the community, knowledge of cancer amongst frontline health workers, and it would also conduct an economic and process evaluation. So in terms of outcomes and significance, so as I said, this study hasn't been funded yet, so it's not certain it's been done, but if we're not successful with this grant scheme, we're going to try somewhere else. So eventually, I feel that this study will be done. It's just a matter of finding the right funding program. But in terms of the outcomes and significance of the study, what we hope to see is we'll assess whether the intervention leads to an increase in screening, improvement in community and health worker knowledge, and improve access to follow-up care. Secondly, we'll develop community-based programs to address the existing barriers to screening that result in preventable deaths. And then thirdly, more broadly, we'll build community and workforce capacity. Thank you. I welcome any comments and questions.
Thank you, Prof, for the wonderful presentation. At the moment, please take a seat here in the orange couch. Yes, and wait for the time for the questions when everybody is done with the presentation. At the moment now, we are calling on our next presenter. I thought somebody will raise a hand and ask me, where is the second program director? He disappeared in the group here in the center, and now we are going to see him wearing the second cap. The first one was being a program director, now is a presenter. The presenter now is Dr. Luvuyo Bayeni. Dr. Bayeni has done MPC HB at Medunsa and MBA at Nelson Mandela University. He's a product of Eastern Cape Department of Health, having served in the following roles in the department. He was the clinical manager. You can't hear me? Sure. As I was saying, he has been serving in different roles in the department. The second role was a provincial program manager for circumcision. The third one, he was acting as a CEO in Tower Mental Health Hospital. The fourth role, he was acting as a CEO in Livingston Hospital, and also acted as a district manager at Joe Gabi, and also acted as a technical advisor for MEC Health. Now, he has been borrowed by National Department of Health to serve as a chief director responsible for human resource for health. Let us welcome Dr. Balen to the podium to do his presentation.
Thank you very much, co-program director. I think because I'm home, she's giving hope to home that I'm just borrowed. So anything is possible. I may come back if I'm borrowed, or you can go and demand me back because I was borrowed. Thank you very much. I come bearing gifts. Someone has donated, and I'm proud to be the winner of the Ford. There was a draw. There is a Ford that has been won, so I'm the winner of the Ford. You'll get your key later on. Thank you very much. I've just been asked to just highlight and brief on how we have been doing in terms of the Human Resources for Health Strategy 2030. And in terms of the approach, it's just to flag where we come from and what are the parameters of the strategy and how we have been doing as a department. And of course, we have been consistent in trying to remind wherever we go, especially when it comes to reminding people of the patient journey and highlighting what does health encompass. We do note that indeed we would expect ordinarily patients to be picked up, EMS, and then sent to primary healthcare, referral system and all that. But the reality, colleagues, is that the system is not always controlled by us, and patients would sometimes do what they think is appropriate for them. So if you see there that there is footsteps and there. It does not mean I have been asked to be a brand ambassador of Hang 10. I am not promoting Hang 10. It just tells you that a patient can walk in here, walk in there, walk in there, walk in there, without necessarily following what you prescribe to them in terms of the pathcare. So that's what it means for us to say, in terms of the healthcare system as well as human resources for health, we just have to have all that patient journey in mind to say, how do we capacitate the system, how do we prepare, and how do we plan in terms of the workforce management. But importantly, what is key for us now in this round is the part that talks about retention to the relative investment that has been made. Because the health workforce is not only so much about bringing you, but it's about what do you do with what you have. And if we've been investing, how do we then get value add out of it and realize our investments thereof. But of course, we have also been mindful that at the end of the day, we are dealing with trying to sustain a healthcare system, which of course has got its own limitations, but also should be anchored in something that is fundamental as to what is it that we want to achieve. And what's important is the base here, especially these two blocks of people that are executing they are executing capabilities as well as the operations. And what we're saying in terms of the HRH, we should always be mindful that as much as we need people at the top to lead us and to tell us, but our outcomes depend on these two people in terms of what impact we want to have. So in whatever we're doing, we should be able to try and balance and see if we cannot try and make a difference and focus on the issues that deal with the focus core business as well as the organizational structure issues. I came across and I felt this one is also applicable to my space and the work we do at HRH. Productivity is never an incident. It is always the result of a commitment to excellence, intelligent planning, and focused effort. So that's what keeps us going in the HRH space, as we learned from Paul Mayer, that at the end of the day, if we all agree that we want people to be productive, we must put in some intelligent planning, but also we must appreciate that there would be efforts that each and every one of us must put in. HRH must be led, and there is an intentional approach and an intentional focus on issues that deal with leadership within the strategy. Because amongst other things, it's a realization that you need the strategic leadership capabilities for health workforce for us to move forward. So there is some reference that is there on the strategy that deals with the issues of strategic leadership. But what we are saying as well in terms of leadership versus hospital governance, there are elements and principles that we are advocating for and trying to highlight to say, at the end of the day, we need to know what governance is, because now we are saying there is leadership vacuums, there is governance deficiencies, but we're not there to guide to say, how do we then strengthen this space of governance, especially within the hospital space? So we are also expecting that there'll be some achievement of strategic goals even from the hospital space, sound board CEO relationships, because we do have hospital boards, we do have CEOs as managers, but we're not sure of what type of relationship is there between the two structures. And of course, we want the institution to be led such that there is a unity of direction, unity of command, unity of accountability and responsibility as well. But of course, we must never shy away and not forget that there is also a notion of public ownership, self-improvement, equality management, as well as understanding the cost of governance. But of course, there is also an issue of the organization we are in. How do we lead it? And what are the issues that we want to ensure that in the health workspace, health space, what is it that we want to achieve? So we are reminding that there is issues of development of comprehensive clinical governance framework, but importantly from the HRH perspective is that we need to educate workforce on key aspects of clinical governance framework, highlighting their responsibilities for improving safety and quality. And not expect it that it's an issue of a clinical manager, it's an issue of a nursing manager, or an issue of a doctor or a nurse only. But our health workforce within the facility should understand that all of us have got a role to play, especially towards improving safety and quality. But of course, we need to review policies and procedures, as well as review the results of clinical audit. The same goes with clinical leadership, that we need to understand and also perform delegated responsibilities. But importantly, is the issue that talks to issues of conducting clinical audits to ensure that clinicians operate within the clinical framework. What I am being paid to come and talk about is this one. The issue of HRH strategy, this is what I refer to as my Bible since I was borrowed from Eastern Cape. It's a green book, and I try to make sure that I understand all these chapters. I might add in some few hymn books, but this is my Bible. The department has endorsed in 2020 an HRH strategy which is having a time span of 10 years up until 2030. So it's appropriate for us now because we are in 2025. We refer to it as a midterm, and we just need to reflect and see whether we're coming or going. But the purpose of the strategy is to facilitate implementation of sustainable comprehensive health workforce interventions. But also it's underpinned by the issue of consistent supply and management of a competent health workforce for optimal contribution towards meeting the population needs. Especially in this time or this era of limited resources, one of the things that we are highlighting from an HRH perspective now, and when I preach, I always wish that I'll have people that are converted and will have more disciplines, disciples, as Jesus Christ was doing in his journey. So now, when we meet people that raise challenges of money when it comes to employment, we are reminding that in terms of the healthcare system or the health workforce, whether there is money or not, we must be reminded that a health workforce in its nature, it's a key driver to inclusive economic growth. If you don't have a healthy society, whether you bring investors or not, that country would not succeed in terms of its economic drive. So that's what we are trying to say to people who've got money, that even if you must limit it, but understand when it comes to the health workforce, we are contributing to the economic growth. So an investment in contributing to decent work and job creation, particularly for women, is what we are also trying to remind all those that are talking about investment in terms of human resources. But of course, at the heart of an efficient and well-functioning health system, when empowered with optimal skills mix, distribution, competencies, and standards. So what we are also bringing to the fore is that, yes, we are all excited that we are heading towards universal health coverage. In South Africa, the component or the model that is being chosen now is that of an NHI. But the reality is that without any human resource interventions, it is there clearly that there can be no delivery of universal healthcare coverage without skilled and enabled and supported healthcare workforce. But also we are also trying now to move in the line of economists as well. So when you talk about us in terms of human resources, we are reminding and adding to the whole discussion of finance and investment that we are also a capital. If you go around and ask anyone that you want to start a business, they'll ask you, do you have capital? So whatever space you are in, when you talk something that has got to do with investment, business, and productivity, they'll ask you about capital. And our issue is that we are saying, we are this capital, and people must start taking us serious. Because whether there is money or not, there's a lot of capital we are bringing. We are bringing knowledge, we are bringing creativity, we are bringing ability, skills, education. So we are the capital that all the sectors need in terms of surviving, striving, and improving. So that is our language now. So next time when you talk to people, tell them that human resources for health, we are the capital, human capital that the organization needs. And please convince them, as I continue to convince them to give us money. We've got 5 goals in terms of this Bible of ours. The first goal talks about effective workforce planning to ensure HRH is aligned with the current and future needs. The second goal talks to institutionalizing data-driven and research-informed health workforce policy, planning, management, and investment. The third one is about producing a competent and caring multidisciplinary health workforce through equity-orientated, socially accountable education and training system. And I think earlier on, that's what the discussion about the models of mid-levels are also trying to remind us and talk to. Ensure optimal governance and building capable, accountable strategic leadership and management in the health system. And lastly, build an enabled, productive, motivated, and empowered health workforce. Those are the 5 goals that we are trying to achieve in this 10-year patina. We've been in the strategy now for the last 5 years. We are heading towards the closing it in the next 5 years. So now, just to reflect and give you a sense of what we've tried to achieve or how far we are. In terms of the first goal that talks about effective workforce as well as planning and alignment, We are very much considerate of education and labor market needs, supply and demand mismatch, as well as the filling of funded positions. But we can confirm, colleagues, that we have tried to move. If you look at the three main objectives in that goal that talk about the HRH strategic functioning, we feel that we have achieved that. And we are still promoting and encouraging provinces to develop their own provincial strategies. The strategy also was pushing or motivating that we should establish what we refer to as a health workforce consultative and advisory forum to meet 6 monthly, but also amongst its tasks is to ensure that there is an annual HRH in Daba. So we can report to you that we have managed to launch that last year, as supported by the partners, and it's supposed to be in its first year of term this year. The third issue on this goal is about achieve consensus on health workforce planning approach or model, including financing of health sciences, education, and training. We are actively participating with the department having co-chairing platform in what we refer to as the Joint Health Education Science Education Committee, JSEC, which is a platform that is between Department of Health as well as the Department of Higher Education and Training. But we have gone further to rob in Department of Treasury, National Treasury, to participate there. So we have moved there. Terms of reference have been approved in that space. So we are seeing some light. The second one that talks to the data issues, loosely translated, we talk about health, human resource information system. We even have a directorate that deals with that in the department. So initially we're supposed to explore research conducted on HRH and access progress. We had a limited internal capacity on our part, so we haven't moved, but through platforms of such as these and the networkings, now we know where to go to, and we'll be able to start implementing that part. Of course, we are also proposing upgrading of PESAL system from the generic of health specific to linkage. Where we want in this space and where we are heading, we have achieved it, but we are improving on it. By the time we end this term, when I meet anyone in the street and they say, I am Dr. Luvuyo Payeni, I will say, okay, what is your ID number? And then I'm done. From that, I would click on the button and I would know if you are registered with any council, where are you practicing now? Are you in the state or are you in private? And that's what we want to achieve, so that we have a sense of who are the health workers in the country, whether they are in private, we're in the Bahamas, but we should know as to who are the health workers in the country. And then, of course, that information will be harmonized with the statutory bodies so that we know exactly, because all of us, we know we must register. Even though you are still enjoying your holidays somewhere in the Bahamas, but registration with the council always comes first. So we'll make sure that we know who exactly you are. But we want to create a data warehouse, and we are busy consolidating that. There is a program called Accelerator Program that we are working on. Like we have said on the first one, the issue of research unit, we still have to action that one. Education and training, determine resource requirements and mechanisms for decentralized training platforms in the health space. We have reviewed the guidelines of the regional training centers that will be presented at the National Health Council Tech as well as the NHC. We can confirm that February, last week, we had a 2-day session with all the provincial regional training center managers. So there is work that is moving in that space. Engage professional councils to develop a unitary approach to core competency curricula for all health workforce. We still have to action this one, but we are having access to the Joint Committee of Deans for Health Sciences faculty. The issue of strengthening relations with academic institutions, that's why you could gladly extend your invitation to us, and we are here, and I'm not here alone, I'm here with my boss. So we are making sure that relations with academic institutions are strengthened at all times. And the issue of higher education, we did mention that there is joint committee which deals with that. On governance, governance principles, I think the first 3 slides I was mentioning was indicating our approach in terms of governance issues. But the other issue that is important for us is the issue of making sure that we we safeguard the public interest. And I think from our perspective as a department, one of the things that is coming up that we are very much concerned about is the caliber as expressed by the ethical and behavioral issues that we are seeing with the caliber of our graduates. So we are very much concerned in terms of public interest as to, are we producing the right caliber? Are they having the public interest at heart? And it is our responsibility as a department to make sure that we safeguard that place. People management, that is now goal number 5, review of available remunerative incentives. So my colleagues, I did not come with the issue of reviewing committed overtime. It was signed off in 2020 when I was still working in Eastern Cape. It did not come with me. There, you see it now. It is not me, it is in the strategy. So we are reviewing our policies, colleagues, all 5 of them, not only committed overtime, community services is being reviewed, rural allowance, OSD. So it is a strategic issue. And of course, it is necessary because with time you need to know, are some of these incentives and policies still relevant? Is the applicability thereof still the same as when we started before? So that is where we are. But of course, we're still interested in attraction and retention. As a department, colleagues, whether we've got money or not, we still strive and want to be the employer of choice. But of course, we are saying we are not the only employer. And that's what people must understand. When you are a graduate, public health is not the only employer, but we want to be the employer of choice. So there is that balance that people must understand. And of course, we need to review the issue of performance management tools. But importantly is the issue of a welcoming and a conducive working environment. That is where we are busy hammering and drumming into our provincial counterparts that we need to really take serious the issue of employee health and wellness and make sure that we are responding to the strategy of creating a welcoming and a conducive environment. And of course, we must ensure that we minimize the risks that are there with the health workers at risk. I think that is where our labor friends know that we also take them serious, that we don't want them to be at risk in our workspace. So we have done some work there where we have also tried to assist the employee wellness team to launch a national employee health and wellness forum last year in August. This is just to explain what do we mean by the health workforce and consultative forum. It is in the strategy and it is well prescribed as to what we expect out of it. And just to ensure that we are moving towards a stakeholder engagement opportunity where we feel as a department we cannot do everything alone, especially when it comes to issues that deal with the health workforce. Research has been presented here earlier on, practices and exercise have been presented, and this is what our health workforce consultative and advisory forum is going to assist to say, where are we now? What is the relevant information and where do we think we can do better going forward? The membership is a joint membership between us as a Department of Health, where there's 5 officials from the department nationally and 4 from provinces. We also have sector departments, SAMS and DHED, as well as partners. We've got academia, strategic experts, professional councils, as well as the private health. In conclusion, colleagues, ours is just to remind and to report in actual fact that we are very mindful that there is an urgent need to improve leadership, especially when it comes to clinical governance. Because whether you look at it from a litigation point of view or from efficiency point of view, we feel that if we can strengthen and do much better in clinical governance, we can try and achieve certain things. But also the implementation of the strategy has been impeded by financial constraints, as evidenced by the National Treasury decline in terms of funding elements and strategy thereof. But also health reforms provide an opportunity for review of the strategy to align with the preventative healthcare as well and attain universal healthcare coverage. So there is nothing wrong with us reviewing even the strategy itself to see if we are still in line. And the other issue is that there is an urgent need to address internal culture. As an organization, colleagues, I don't think we are telling lies when we say the organization needs some cultural review. Whether you look at it from the perception of work ethics, coming on duty on time or late, staff attitudes that patients complain about, our own efficiencies as managers, wastages, and all those things. So there is a need for us to just look and address our internal culture as an organization. But importantly, especially from an HRH perspective, earlier on there was a presentation that was talking about mentoring. We are saying maybe that's what we need even more. That let's try and find a culture of coaching and mentorship within the organization, and of course having expertise from outside. We go around advocating that let's prioritize and align, especially with partners and sectors that can ensure that the strategy is used as a planning tool even in their departments. And like I've mentioned, we are proposing and continuing to advise provinces to have their own internal provincial strategies, because there are things that are unique to different provinces. We might be reviewing rural allowance, which is very much relevant if we're talking Gauteng, for instance, where, by the way, Val will tell you that they feel they are more rural than Johannesburg. So they also want the rural allowance. But here you've got your Lusikisiki, you've got your Mkandulis and all that. So provinces must be able to look at their own provincial strategies to be able to meet their needs, especially when it comes to issues of retention and attraction. Because that must talk to what is it that we are saying as Eastern Cape. And of course, we want to make sure that goal number 5, which talks to our wellness, is also prioritized, even as provinces. We have also requested provinces to look at what we refer to as focus and strengthening of the nursing and EMS college capabilities with a detailed project plan, because we know both colleges are coming from a backlog of having to meet needs and requirements by DHET. But if you look at it now, we seem to have just left them alone. We are not there to say how then do you maintain those standards that you have submitted to DHET. The issue of the clinical governance, I think I've overemphasized it, and that there must be some leadership from the clinical governance side. And lastly, we are saying this time around, we want at least to go along and also introduce issues that deal with monitoring and evaluation in terms of healthcare workforce issues. In all human affairs, there are efforts and there are results. And the strength of the effort is in the measure of the results. So if we don't have results, this effort of us being here might have been regarded as being useless by other people. So it's always important that we must make sure that there are results to just strengthen what we're doing. Colleagues, there's gold in human resources for health, but the only problem is if you are pulling apart, the other one wants to go that side, the other one is going that side. So we are here to say, let's work together. Let's all go and dig the gold. Let's see how we can make use of it, whether it's talent, whether it's mentorship, whether it's support, and whether it's appointments, but let's work together as a team. Thank you very much.
Thank you so much, Doc. You can take a seat on the orange couch. You'll be waiting there until we are done with you asking questions from you. And all the bosses here, yeah. And Dr. Payeni now is finished with his presentation. And now we are going to invite on the podium Dr. P.C. Mahlat. Then now, when you were talking of him, I'm going to introduce him, although I was cautioned about this. Dr. P.C. Mahlat founded the African Institute of Health and also runs the Selizwe Leadership Academy. He serves as a Deputy Director General for Hospitals and Human Resource at the Department of Health of South Africa, a role he has served in an earlier stint as well. Before then, he was a COO of the South African Medical Association, whose formation he spearheaded. Dr. Percy contributed to health policy development in various aspects, but chiefly in the health workforce field. He played a major role in the development of the World Health Organization's Code of Practice on international recruitment of health personnel and participated in the core expert group on health worker retention in remote and rural areas. Previously, he chaired the Ethics Institute. He chaired the Ethics Institute of South Africa, and he was a member of the Council of the University of Limpopo. Dr. Percy received his MBCHB from the University of Natal Medical School, now the Nelson Mandela School of Medicine. His Master's of Philosophy from the University of Stellenbosch, and his PhD from the University of Fort Hare. He has a certificate in advanced management from the Manchester Business School. He is a board member of Fort Hare Trading Solutions at the University of Fort Hare Company. He is a fellow of the 5th class of the Africa Leadership Initiative, South Africa, and a member of the Aspen Global Leadership Network. He has recently self-published a book entitled Strategic Management of Professional Health Workforce, a South African Policy Perspective. And now I hand over to Dr. Percy to deliver his speech. Thank you.
Thank you, Mandobanga Mameli. No, thank you very much. I will try and go through. I was asked to talk about building HRH capacity. Oh, okay. In the light of limited resources. And you will all remember that there was something called Circular 49 in 2023 issued by DPSA in conjunction with Treasury, which was basically limiting the employment in public service. So that would be in the context of that, followed by the austerity measures that, have been strengthened over time. But I thought let me start by saying that, of course, we're experiencing challenges in funding education and training and linked to employment. That is, you educate, you train, you graduate, but then the employment. But I want to emphasize what Dr. Bayeni said earlier on, that the fact that you've been educated using state money does not entitle you to be employed by the state. We seem to have major problem, especially with our young doctors, who actually say because they're educated by the state, therefore they've got an inalienable right to be employed by the state. I think we need to actually deal with that because no other profession has that in its mind. Number two, there are lingering challenges in HRH. Some of you hopefully are advanced enough to remember that Professor William Pick produced a report in 2001, which was looking on human resources for health. And there have been several studies, including the country contributing massively to quite a number of, studies and work by the WHO. And of course, there is one thing that we have managed to keep on as a country: training quality under and postgraduates. That is the reason that they would remain in demand across the world, because nobody recruits poor quality. They always go for best quality. 1994, we had a big problem, because when the world started recruiting nurses, they actually went for our most experienced nurses, theater nurses, ICU nurses, even those that were working in the wards, were experienced managers. And we found ourselves in a big, big, big challenge. That is what later led on to the OSD. Because of those experiences, because we're trying to find out how do we respond, policy-wise. One of the major leaps that has been taken has been to peg nursing and EMS at higher education level. But I thought let me just share with you what the different accountability roles are. As the National Department of Health and basically the health sector as a whole, we've got to define the skill demands and training parameters for our health sciences. That is why in the National Health Act, no new qualification can be introduced without the Minister of Health acceding to it. Not even the Health Professions Council, whoever can do that. That responsibility lies squarely and 100% with the National Minister of Health, because it's a mechanism to try and equate the demands with education, requirements. Higher education and training must make sure that there is effective planning for the supply of healthcare professionals. That is why education institutions, they actually have to submit to the Department of Higher Education and Training their 10-year student planning, so that the department would then be able to lobby for funds to be able to fund, those programs. They must go through the Council on Higher Education, follow all those accreditation processes. So you get the national department this side saying this is the caliber we need. Then higher education would say, okay, that is what you need. CHE, you engage with universities, colleges, what quality would be required, therefore what quality programs are there. Then you get to a national treasury that says, what is it going to cost? So that they can be able to then say what kind of subsidies they're actually going to provide to the universities to be able to do that. So the higher education institutions are responsible for curricular development and quality. Provincial health departments then come in providing the employment platform over and above the training platform and research platform. So if you actually look at that, those four, of course there are others like your medical research, which actually conducts the burden of studies, projects for us, so that then we can be able to know where the challenges are. Because if it is estimated that in the next 10, 15 years, these are the problems that we are going to have in terms of existing and new diseases, medical research should then sound the warning. So there is that complex, relationship between all. It's not just limited here. There are many others, but I thought I would just take this. I'm spending a bit of time here because it's important for us to understand what the different responsibilities are. So you cannot get a university just setting up a program, enroll students without ensuring that both Department of Health and DHED are in agreement. I'm not going to name, there are universities that have done that before and have faced litigation afterwards because they invited people to enroll and said, no, you'll get work in the public health sector, only to find later on that is actual, in Zulu they're saying, amangal hlaza, So, what funding streams do we have? We've got a variety of funding streams that Dr. Bayen here is putting his head together with our, finance people to say, how do we harmonize this so that we stop having multiple sources of funding that would end up, clashing against each other. We've got a clinical training grant. There's subsidies to education institutions from higher education, bursaries to students and trainees, the health professions training grant. There is private funding. It may not be that big, but it's actually there. There is also the health and welfare sector funding that we have not exploited to the full, that we should. Of course, there is need to streamline and ensure equity because there is a challenge that you find some programs are more funded than others. And those that are less funded, you might find that the ones that are more needed at a primary level. An example is the rehabilitation professions, physio, occupational therapy, audiology, speech therapy. Those are not funded, adequately. But those are actually that you need, because of the various challenges that we have. Of course, I won't go through a lot of that. I think the second one is very important to highlight. Limited spaces for under and postgraduate education and training. We actually are doing well undergraduate, but postgraduate we've got problems. And if we don't produce specialists now, in 10 years' time, we'll actually kick ourselves and say the consequences of a decision that we took are hurting us. remember, specialists across all categories, especially nursing. If we don't deal with those, we're going to have a problem. Limited posts for employment in the public health service. Of course, I mean, that's a function of a functioning or non-functioning economy. Overloading of public health facilities. Then I would just want to emphasize the last one. Major problems with economic development. A general youth unemployment that we're facing. Oh, Professor Cheta is not here. There is a character that we share between me and him. Seyithetha injalo into. If you look at your program, it's got some insertion there that iphume ecaleni kule nto kuthethwa ngayo apha. It says 10 years ago, it was unheard of for a doctor to be unemployed. Where did we go wrong? So you can interpret that in various forms. It's asking a genuine question, but then that genuine question, why should it be asked of doctors only? Number two, it could be showing a siege mentality. And uyayibona nalo sisu lapha uthe. She's really under siege. That relates to the last bullet. Our country has got a serious problem of youth unemployment. We've been seeing it far. It's come to our doorstep in the health services. Yes, we must cry foul, but we've got to find ways of dealing with it. And it can't be government alone that deals with it. Professional associations like SAMA are very important. SAMA to whoever it is, to deal with that problem. So I'm actually saying that is, to me, it looks like a siege mentality. That, look, we've been so privileged, the privilege is going away, and the whole world is coming apart. It's not coming apart. And it will not come apart. As long as we agree that we are going to solve that problem together, I will share with you what we need to do. Mitigation, Dr. Bain talked about Joint Health Sciences Education Committee. That's a committee between ourselves and DHED. I'm one of the co-chairs with another DDG from DHED. We've pulled in National Treasury to that. One of the things that we've got to do is to define a long-term vision. It's one thing to talk about invest more money in. If you are putting more money into a system that does not have a vision, what is going to happen? The participants there are going to be fighting each other. So the question of leadership is very, very important. So we must define a long-term vision. So we've set up a team that's going to look at that. The other team has to look at the data that we'll use. Where do we collect it? How do we collect it? Where does it get stored? What analysis do we get out of it? And therefore, what information for planning do we actually get out of that? That will inform funding. That will also assist a lot with our research and policy. So those are the 4 subcommittees that we've set up. Now, there is Department of Health, Department of Higher Education, National Treasury, 3 representatives of the deanery in the country. We've actually pulled in the education institutions. We've also pulled in the regulatory bodies, your HPCSA, Nursing Council, and so on, because we want all those that have got to deal with higher education to be under one roof so that we address the same problem. But there are certain operational efficiencies that we need to do. One, we've got to look at new forms of employment. Shift work Started in Limpopo and doctors ran up and down. But unfortunately, these are some of the things that we actually have to look at. We've got to look at reviewing other HRH in retention incentives. I'm going to pick up commuted overtime because that one is the most simpler, and maybe the RWAPs. Let me start with RWAPs. In Dr. Bayani's presentation, there was a slide on clinical leadership. That is the seniors that provide leadership. But if you've got a senior who's going to come to work at 7, gone at 8 o'clock, and pitch up at 5 o'clock, what do you think the juniors are learning? We're setting a bad example for them. You are away most of the day, then you come back, you want to be paid for the whole day, and you feel entitled to that salary. I must be paid, you know. I was available on the phone. You are not employed to be available on the phone. You've got to be there physically, you know. RWAPS is that problem. And I must say that RWAPS has started with us as administrators, CEOs. You know that the guy is not working, but you actually, turn a blind eye. Instead of saying, look, for this week you actually worked for 10 hours instead of 40, so you'll be paid for 10 hours. And see whether the behavior is going to continue. Many of them say that I'll leave to the private sector. Many years ago, it's my second life in the department now. Many years ago, I had a colleague at Bongani Hospital in the Free State who was faced with that problem. Said, no, these ones are trying to go. I said, call them tomorrow, give them pen and paper to write their resignation and go. There were 4, only 1 signed, the other 3 didn't. Because they know what it is in the private sector. I'm from there, I know it. It's not easy. So people hold you to ransom because you fear that look, just test it. It's okay, go. They will go and come back and want sessions. Why do they want sessions from you? It's not about giving service or something else, Commuted overtime. Eastern Cape has a budget of close to R1 billion on commuted overtime only. That's excluding salary. And for it to employ the doctors that are unemployed, it needs 348 million. So the question is, why not take that of that billion? You just take 500 million. You employ more people, you leave 500 million or 400 for commuted overtime. What's difficult with that? Then doctors jump up and down. No, we want that. Because if you've got 4 doctors and you can employ 6 more, the demand for overtime on the 4 is going to reduce. Simple reasoning. I don't have to be like Prof. Asamani here, who actually thinks a lot about figures. I just use simple reasoning. We're afraid to take those decisions. Then we complain that we're understaffed. We don't have money. We do have the money, it's inside. And I'm happy about provincial treasury is put a foot down on it, that I'm aware. Limpopo decided to go on shift work, and with the money that they saved, they were able to employ up to about 400 recently post-community service doctors into the system. So why would we refuse that it does that? Because then we're saying our colleagues who are young must actually be unemployed, while we actually benefit from, what in many instances we're stealing from the public. I know that the word is going to come out and say that UPS said doctors are stealing. I'm not saying that. But we do have some rotten apples in our profession. So if we don't deal with those rotten apples in our profession and think that treasury is going to pump money, forget it, it's not going to happen. Take it from me, it's not going to happen. Unless we improve on those operational efficiencies and say, what is it that we can trim so that we can be able to get others? You all do it. The cost of living has gone up. you've trimmed your monthly, shopping. You don't buy all those niceties that you used to buy 5 years ago. You buy the basics so that you can feed your families. Why can't we do it? So that we can get these young people in and make sure that the seniors are there to train them. Medical litigation can be connected to that clinical leadership slide because young people are training themselves. They are making mistakes that end up costing the state. And we don't take it back and say, look, Professor Mahlati, where were you when juniors were making this mistake? These are some of the issues that we've got to, and I'm prepared to be on stage to actually, discuss those issues. Going towards the end, we have to make sure that there's frequent engagement at strategic level. Policy developers, the deanery, and the funders. That is why that joint health sciences education committee is set up like that. We need to encourage innovation. We have to move at fast speed on interprofessional education and training. If we don't do that, we cannot sit with training that has been like this for 20 years, 20 years, 30 years. And the innovation must be led by education institutions. Of course, we need to jointly assess the long-term impact of global developments in science and technology. There are new technologies that are actually advancing quality of care. And I always say to people that, I'll use the old example. When laparoscopic surgery hit the market, it actually reduced hospital stay and improved, outcomes. There is a lot, where that is now, where the diabetic, where testers, that you don't have to prick your finger and gives you accurate results. Things like those, there is, surgeries that are actually reducing the length of stay, prostate cancer, and all that. That has not actually caught on in public service. So these are some of the things that we've got to do it. So what are the questions that we assist with, at that committee level? How do we create an innovative, collaborative, and adaptive learning environment? How must the vision be integrated with the notion of development? We always talk about South Africa being a developing country, a development, a trajectory and all that. From an education and training point of view, how do we, integrate that? How should the vision position the country internationally? How do we make sure that our health workforce remains internationally, globally competitive? I think we've had examples here, where in terms of research, twinning and all that. Of course, if we reduce our standards, they will dump us. How do we make sure we actually keep it high at that level? Of course, very important, how should we finance the vision? South Africa took a view before 1994 that we are going to be a country that advocates for human rights across the world. That's a very clear vision. It's been costly, but it saved so many nations across the world. It's been a beacon of hope for humanity across the world. So take it in that, view. How do what we do actually assist, not just to propel the country forward, but also to make sure that the advantage that we have actually remains. So just one last comment that there was an issue about the community health workers who are grappling with a challenge. We've got about 50,000 community health workers in the country. And the big challenge is, do we employ them in public service or not? And in the light of the challenges that have come with that man with that hairstyle, across the Atlantic. You know who he is, We've been actually put in a tailspin, but fortunately, we buy our own medicines. But from an employment point of view, 15,000 people suddenly becoming unemployed is a huge headache. So there is a lot of work that we actually still have to do around that. The other one is the Nelson Mandela Fidel Castro, a medical training program in Cuba, which seems to be going down and then going up. And there are huge challenges from a financing point of view. We do hope that WSU will be able to come in as a strategic partner to localize that program so that then we can, over time, stop sending our students there, but they actually be trained here. Thank you very much.
I did know that the audience will do it without being told you can clap for talk. Now, without wasting the time, because time is a little bit against us, we've got the last speaker before we can have our questions to them. Now, we'll be calling on to join us in the podium, Professor James Avoka Asamani. Professor Asamani is a health economist and health system expert who works with World Health Organization as the team lead for the health workforce for the African region. James' core experience is in health systems, focusing on the health workforce, health economics, health planning and policy, and decision analytic modeling in health. He has published widely in those areas. Before assuming his current position, Professor Asamani worked as a World Health Organization technical advisor on human resource health systems, leading technical support for 20 countries across East and Southern Africa. He also worked as a health economics advisor in the WHO country office in Ghana, and previously was the head of health workforce planning and budgeting unit of the Ghana Health Service. As a health decision scientist, Professor Asamani has led several transformational initiatives and conducting cutting-edge health system analysis that have impacted health policies and planning across health systems in Africa. And his recent works on using health labor market evidence to shape planning has stimulated thousands of jobs and hundreds of million-dollar investments from governments and partners across several countries in Africa. Prof is a Commonwealth scholar with a PhD in health sciences, specializing in health modeling and workforce planning from the Northwest University in South Africa. He also has an MPhil degree in nursing, specializing in healthcare management and human resource for health from the University of Ghana, and an MSc with distinctions in health economics and health policy, specialized in decision analytic modeling from the University of Birmingham in UK. As a health force planning and health labor market methodologist, he has developed tools and methods currently used by more than 15 countries across Africa, Southeast Asia, the Americas, and Europe for health workforce analysis, policies, and investments. Professor Asamani is an extraordinary associate professor at the Center for Health Professions Education, Faculty of Health Sciences, Northwest University, South Africa, where he contributes to research and supervises doctoral students. He is also an editor in several globally reputable scientific journals. That is Professor Asamani. Let's give him a round of hands, then we can over to him. Thank you, Prof.
Thank you very much, Madam Moderator, for the very kind words. And good afternoon to everybody. it is usually a bad time to stand in between people and their lunch, especially when they are tired. So I am very much aware of that, and I would skip many of the slides that I prepared because the previous speakers already did justice to most of them. And it's usually very hard to speak after a luminary like Dr. Percy just finished talking. So I might only end up confirming a few of the things he told you without numbers. I may just put a number around a few of them, but there's nothing really new here. So I have been invited to discuss with you around health labor market analysis in selected African countries, and particularly looking at projections to 2030 and beyond. Because we have done labor market analysis in so many countries, I decided to look at what is the overall picture across Africa, and where appropriate, I mentioned a few countries as examples. Okay, sorry. Okay, so this outline is what is in the slide. It will be made available. Hopefully, Professor Mabunda would share with you if you may need it to use for something else. Now, the WHO Africa region, we typically work with 47 countries in the continent of Africa. In these countries, in 2022, the total population across this country was 920 million people. 2 quick points here is that of these people, we have roughly 542 million people who have reasonable access to health services, and 478 million who have no access to good quality health services. So if you look at it, it's a big issue. From this, there are about 5 million people who die, whether they have the access or not. 2.5 of those deaths are deaths that resulted from things that could be averted if they had access to good quality health services. So we say they are amenable to health interventions. Of that, 48% of them died because they used the health services, but it was of poor quality, not good enough to save them. But they could have been saved if the services was of good quality. 52% died because they simply did not use the health services, they didn't have access. Now, if you take a look at this one, this is number, but it represents human beings. It could be anyone. You could have all the money. You could have all the connections. But if you unfortunately fall in at a place where the service is so poor, you might receive the service, but will not survive it. If at a place where the service does not exist, you don't even stand that chance. I will come back to this. So think about them as a quantity problem for where the 52% who don't have access, that's a quantity problem. And then for 48% who have access but still die, that's a quality problem. And you can argue that this would be connected to many aspects of the health system that you already saw from Professor Robina, right? Robina's presentation. But much of it also depends on the caliber of workforce that we produce. I will not repeat these ones because Professor Robina and others spoke about this, showing us that if you look at the workforce per capita, that is workforce per 10,000 people in 2006, compared to 2022, Africa still remains like a place for bloodshed. 2006, the darker areas where we have fewer workers. 2022, nothing much has changed, despite all the big efforts that has been made. But to understand all of these issues, we are going to look at this from an economic angle, so a health labor market angle. If you typically go to a market, you buy and sell. You make choices as what to buy, who to buy from, what price to take and what price not to take. And the ones selling also make decisions about how much to sell that they can make their profit or at least break even, and how much that they can go below that. That is what we are basically going to do. And this particular diagram you see here is the theoretical diagram we usually try to follow, starting from what makes somebody wanting to become a health worker in the first place. In terms of education, we try to quantify. And from there, they qualify to join the pool of health workers. Some bound to find jobs, others maybe not. Some will be forced out of the labor market through debt, through retirement, change of jobs, among others, and some might migrate abroad. And of those employed, where are they working? In the health sector itself, in the other sectors, among others? And are they adequate to provide health services that the population really needs? Are they doing the right things in terms of quality? Are they distributed properly so that there's equity in access to the health workers? All of that is what we do in the labor market analysis. And under each of these, there are things that we try to find out what policy levers, what policy change can be made to address any challenge that we find. Most of the challenge we find, we term them either labor market mismatches or labor market failures. So we would touch on a few of them. Some of these policy levers, Dr. Percy already elaborated on them, and it is now irrelevant to mention. But 3 quick points before we proceed, though, is that I will touch on these 3 points. One is the supply of health workers, which is how many people are available, trained, and ready to work. That will be influenced by your education pipeline, how many are coming in, and how many will come in from abroad. And that is the inflow. And it has an outflow, which would look at retirement, death and disability, out-migration, and career change. All of this would influence how many workers you have going forward. And you will see later that South Africa actually needs to start paying attention to this one. If your inflow is less than the outflow, this is a massive jump, 70% jump, comparing 2022 to 2018, where there were just 150,000. So you can see that countries are putting a lot of effort in training what? More health workers. But one thing, 6 countries are the top producers, and those 6 countries are those who are really driving this massive increase. The DRC, Uganda, Ghana, Ethiopia, South Africa, Nigeria, and Tanzania are the top producers. So these are the ones that are producing, particularly the DRC. Also, we see the private sector is contributing a lot more, putting in money to train health workers because they want to make profit from the training. So that is also influencing the expansion. But when they come to the absorption, the recruitment, they are doing 22%, not matching the 40% that they are putting in the training. So the public sector would plan, like Dr. Percy was saying, try to control the production so that they can absorb. But if the private sector is driven by profits, they will produce more and then hope that the government will take. Eventually, what we have in our hand is unemployment. And you will see that pretty soon. So that takes me to the issue of what is the total stock and supply in the region. As of 2022, our last count shows 5.1 million health workers in Africa, here referring to the 47 countries WHO support in the African region, which is an increase over 4.3 million in 2018 and 1.6 in 2013. You can see a massive improvement. And this is how they were distributed. A little over 550,000 community health workers, more than 330,000 doctors, 1.7 million nurses, 17,000 plus pharmacists, 25,000 dentists, among others. If you were to pick this across different countries, here using 5 occupations, doctors, nurses, midwives, pharmacists, and dentists, because for these 5, the data was consistent for all the countries, so it was very easy to put them together and compare. This is how the improvement has taken place over time. You can see South Africa, for example, because we are here, let me mention that, has improved slightly over time. But you will soon see that improvement can't disappear if more is not done. So this is looking at the quantity issues. So of the 5.1 million health workers we have, what do we know about the quality? I am sorry, but I don't have good news on this one. There's been big studies that has been done. For example, across 11 countries in Africa, and looking at more than 16,000 health workers were given clinical scenarios. You read the scenario, you provide your thought thinking about the diagnosis and treatment, and they compare with what is the standard on paper in terms of national policy. What was found is not very good. 60%, most health workers got 60% of the diagnosis correct, but 35% got the treatment right. Put the other way, health workers will not get 40% of your diagnosis correct and will not get 65% of the treatment right. Is that not scary? Do you need further explanation why 48% of people access health services and they die of poor quality? So we can now begin to draw the conclusions. The study also found further, having more academic degrees does not add much to the competencies. So having a lot of chain of degrees, you write your name, comma, PhD, MSc, MPH, M. all of those ones do not add much. Again, younger people tended to be more competent than older ones. Are you happy with that one, young people? So this reflected something, that maybe there's an improvement in something, either in curriculum or the way the people are now taught, or maybe the use of technology. However, that pace of improvement to lead to 10% change in the quality of services will take us 25 years. So it's so small that we can't rely on that level of improvement to become better. Another study, which involves 79,000 health workers, also across 10 countries, and here they actually ended up even reviewing patient records to confirm things, found one thing. In all our effort to address the lack of competencies, we ended up taking health workers from their duty station. So there was a 35% absenteeism rate among the health workers, but only 4% were truancy. The rest were people who had been sent to go for training, to go for that. And so more or less they were authorized absences, but they ought to have been at work at the time that they were not there. This same study also found that when they come to treatment accuracy, it's 56% in terms of diagnosis, and 68% of health workers would usually get your diagnosis treatment, your diagnosis about 50% or less. Again here, the public sector tended to do better in identifying common illness and treating them well compared to the private sector. The private sector is usually better when it's a complex case, you go and see the big consultant specialist or something. And rural areas tended to pay more attention to the patients compared to even urban areas. So here again, telling you about attitude, about competencies, among others. Just some of the issues that Dr. Percy was mentioning earlier. The next one I want to talk to you about is migration. We have a bucket now. We are training and putting in. You know how many are coming in from training, and we know their competencies in that bucket. And now let's look at the leakages. In Africa, 1 in 10 of our doctors and nurses that we have trained are already abroad. It's not that they are already abroad. 1 in 10. What is more worrying is that in the last 3 years, we've done large surveys among health workers, and we have found one thing. 42% of the health workers currently available have intention of migrating one day. 42%. So this tells you that people want to go. Why they want to go? The obvious, you know it. But now one thing is this. When we look at the countries they prefer to go, for English-speaking countries, it's typically the UK, tops at number 1, followed by the US, followed by Canada, followed by Australia and New Zealand. Then for French-speaking countries, the obvious, France, Canada, typically. Then we see a new dimension of people wanting to go to the Gulf countries, and Dr. Percy is one of the experts in that area globally with migration, so he has all the figures. But one of the things that we have come to realize is that if you go to Europe, their doctors, you have a lot of them who are retiring soon. 30% of doctors in Europe and 20% of their nurses are at the verge of retiring in the next 5 to 10 years. Their education system is insufficient to fill this gap and address new demand that will come from the population. It's even more expensive to train and then employ. So they rather spend their money to employ straight from where they can. That means they will pick the best from our countries. So the best here are not necessarily the new graduates. They would usually pick those who are well experienced, are specialized, and those things. So migration is not going away. It has been with us. It will be with us. the earlier we agree that we need to make interventions to address and keep enough for ourselves, the better. Or if we want to train more and send some out, we make that decision also the better. And for every doctor that leaves our shores and every nurse, we lose more than $1 million, approximately $2 million for doctors and 1.2 for nurses. With all the money they send back home when they work there, it does not offset this loss to the country from which they were trained, from primary school to when they qualified as a doctor or a nurse. So let's find a way to deal with the lost investment. But they are also justified to travel. Why? Dr. Percy told you there are no jobs. We have done this analysis and we've looked at countries, the rate at which they are producing workers and the rate at which they are being absorbed. So that's just plain. If a country lies on the blue, that country is just producing enough to absorb. Those above it are having too many workers who are being produced and they are stuck and not being absorbed. Those below it can go either way. Those I have circled, we have concrete data from those countries. Watch it out. So, look at this data. And so our analysis from these 10 countries where we have concrete data show that unemployment among the health workers is approximately 27%. Approximately 27%. But put it in real human beings terms. Look at Ghana. At the time of the analysis, 118,000 health workers were trained, skilled, available, but they had no jobs. This number is now roughly 200,000 in Ghana, with USAID scrapping jobs, and so people become unemployed, and 2 badges have completed 25,000 per year. That is now a huge number. Look at Zambia. Is that Zambia here? 46,000. So these are not small numbers of people, young people who are trained and not employed. You should know that nurses, because they are the majority, they are also the majority being affected when it comes to the unemployment. So more nurses are unemployed compared to doctors. When they were developing the South Africa HRA strategic plan, the analysis at the time showed that 45,000 people who identified themselves as having skills in health were still looking for jobs. This majority of whom were nurse aides, right? Nurse aides, yeah. I believe by now these numbers have changed, but it tells you that a lot of effort is needed to address the issue of unemployment. So somehow we can't blame our young people for wanting to travel abroad. But it is the who travels that is the issue, because it is as a biased selection of the experienced and the specialized. Now, Professor Mabunda, if I didn't show any projection, you would say I refuse to address the topic you gave me, so I've been giving you a few numbers on those ones. So in the African region, what we have seen is that this is across the 47 countries. The number of health workers we have are increasing over time. That is this blue line. If you project it over 2030. The details are published in a paper, so the paper, I showed it in the previous slide, so those of you who can read the details from here. This is a big report that has everything. This is a paper summarizing it, yeah. You can look at the details there. Then when we look at disease burden, we looked at 118 diseases and risk factors that either kill people in Africa or make them fall ill. And country by country, we look at what is the prevalence for that country. The minimum estimate, the maximum, and then the median estimate for each of those diseases and risk factors. Then we look at interventions that must be delivered to address these risk factors and by whom. And we look at how much time each worker will spend to deliver that intervention. And we modeled out how many workers are required. This is what we found on our base scenario for Africa. If we were to look at it, say, assuming all the disease prevalence becomes low, if our health promotion and disease prevention works, what will happen? This is the numbers required, right? Then assuming that nothing works and the diseases increase to the highest point, what will happen? These are the numbers required. So you can see for Africa, any scenario of the disease burden requires more health workers because the projected health workers is the blue line, is below each of these scenarios. So whatever the case is, the argument is always good to invest in different areas, health promotion, disease prevention, among others, but it does not yet replace the need to train more health workers. We haven't gotten there yet. I will show you a few countries that their blue line crosses one of these scenarios. And you can say for these countries, they need to begin to think about optimizing. Here, as South Africa, we need to optimize, but we just need to train a bit more. So our projections show that in 2022, Africa had a shortfall of 5.6 million health workers, and by 2030, that would increase, given our population growth and the shifting pattern of diseases, to 6.1 million shortage of health workers. About 52% of this shortage will be for doctors, nurses, midwives, pharmacists, and dentists. There are lesser talked about occupations that the shortages are bigger if you look at it in terms of relative terms. Like if you go to physiotherapy, you go to laboratory science, those ones. We don't talk about them much, but the details show that those ones, we even have a bigger gap in terms of, in relative terms, in the percentage of the shortfalls. So think about this one now. Each country put in the graph, comparing their worker density. Their density is how many workers you have per 10,000 people, and also your graduates, comparing your graduates with also the need to have more health workers over time. We put them into 4 quadrants. The quadrant that, the category 1, are countries that are struggling in everything. They don't even have enough capacity to produce. So for them, their shortages are huge. They don't have the capacity to even fill it. Category 2, they can train more, but the problem is that they can't absorb them. Category 3, where South Africa is, they have relatively better number of health workers now, but their level of production will not be able to maintain that number over time. So take note of that. That's where South Africa belongs. Then category 4, they have reasonable numbers. Their level of production is high. Their problem over time would be massive unemployment. So now I want to compare South Africa and Kenya, who are here, and compare also Ghana and Zambia, who are here, so that you can see how it plays out in all this modeling. This is Kenya. Look at their blue line, that their workers projected over time is almost flat. Because the numbers that are leaving the system through retirement and migration is almost equivalent to the number they are producing. And the fact that they are also not absorbing much. And look at the different scenarios of numbers required to address their disease burden. They have no scenario to be able to what? Meet those ones. So this is not a country to focus their attention only on optimization. You need to increase and optimize. This is South Africa. South Africa's situation is a bit more dire than Kenya, actually. And I will explain. Because South Africa has what is required to meet at least the minimum service, the minimum scenario. You can see your blue line is above the minimum scenario. But your numbers are reducing over time instead of increasing. And over time, it is at risk of getting lower than the minimum scenario. You know why? According to data from the South African Nursing Council, you had a reduction in 2022, the register reduced by 6,870 nurses. For different reasons, we don't know. Whether they migrated, they retired, or we don't know. Now, if you compare 2020 to 2022, you are having about 14,000 reductions. That's a massive number to decrease in one country. Now, to go further into South Africa, you would notice that 19% of South African doctors are 55 years or more. So they will retire in 5 to 10 years. They don't retire because they go to the private sector. No, but this is the thing. The life expectancy of South Africa, even when you adjust because they are well paid among others, is such that the incidence of long-term illness will come in, and with time, whether they like or not, they have to reduce how much they can work. So the earlier South Africa plans to replace them, the better for everyone. But now take a look at it. Overall, if you add those who are retiring plus those who migrate, South Africa is losing roughly 2.3% of its doctors per year, but it's replacing it by 2.1% from their training pipeline. So there's a small fraction of a loss each year you are beginning to accumulate. So with time, that can potentially have a reduction in the total number of doctors you have. But it's worse for that of the nurses. 24% of the nurses are either 55 or more in terms of age. Retirement is projected to be around 1.9% per annum with 0.1% annual immigration. That's together about 2%. And that is simply because these days South African nurses are not too keen to move like the other countries. So I think they are basically now focusing more about the UK, the US, and a few others. So not big numbers like you would find maybe in Zimbabwe and others. So for nurses, it's a total of 2% loss per year, but your replenishment is just 0.8%. Are we together? So yeah, I've pulled the 4 occupations here for you to see the nurses, those who are near retirement, doctors, pharmacists, and dentists. Look at dentists, 25% of them are 55 or more. Now, so does it now explain why this line is dropping in South Africa? The blue line, your projected numbers. You getting it? The production is below the attrition. In terms of money, because of this, any intervention that you make is not cost neutral. It requires money. In Kenya, in 2022, we did this analysis and we told them that, you know what, guys? This red broken line here is the total amount of money available in the country to employ workers from both public and private sector. And the black line is the cost required to pay the current workers and employ those who are trained. Kenya has a gap. That gap is quite small. You can see the gap between the red line and then the black line. That small gap alone is accounting for more than 27,000 unemployed Kenyan health workers. In fact, in Kenya, I know doctors who are not employed. In Ethiopia, I have been driven in a taxi by a doctor, an unemployed doctor before. So these are not like statistical analysis that we are just saying. They are things that we know the people who are affected. Look at Ghana. It's my favorite example because anytime you are looking at labor market failure, Ghana is a classical example. By the way, that's where I come from, so I know them too well. So their blue line is rising very sharply. You can see that across that moderate scenario in terms of need and almost threatening to reach even the maximum scenario. Ordinarily, this would be good news for the country, isn't it? But you saw earlier, they've accumulated 118,000 unemployed doctors and nurses and pharmacists. So that is not good news either. Look at Zambia. Their blue line is rising quite remarkably and threatening to already meet what? The minimum scenario for their need. They are far from the medium and the maximum scenario, but at least they are crossing the minimum scenario. They are one of the countries with impressive what? Growth in terms of the workforce accumulation. But you saw 46,000 what? Unemployed health workers. So the question is, in these countries, is it better to train and they are unemployed, or is it better not to train and so that you don't have an unemployment problem? I don't have the answer. But I do know that in COVID-19, when Ghana needed to recruit more workers to fight COVID, they recruited 40,000 in 2 weeks. That's because they had unemployed nurses. If they didn't have, they had no chance to import them from abroad. So this is the Ghana situation. We warned them actually in 2020. We did warn them that you were getting to a point where you will not be able to employ workers. Somehow they thought it was just mathematical modelers sounding the alarm bells when there's nothing. But unfortunately, it has come to pass. You see the situation in Zambia, they started messing it up from 2022 between the red and the black line. So that increase you are seeing there, it's not like the Kenyan situation. If you look at the Kenyan situation, we had a circumstance where Kenya could potentially be able to absorb all their health workers. That's this line where they cross, the blue and the red, the black and the red cross. In Ghana, we don't have that scenario. That doesn't exist in the context for Ghana, because the black is rising fast and the red is almost steady. The red is how much money the country has to employ workers. In Zambia, they are like diametrically opposed. There's no way they are getting close to each other unless a decision is made to increase how much is spent on health workers or reduce how many they are training. So this is how some of the labor market analysis can give you current information and forewarn you about what's likely to happen in the future to give you the chance to take corrective actions. Really, for all the countries, we are spending more money on health, but how much health is a priority on government budget is remain the same. So when they tell you, oh, health is our top priority, yes, it is a nice rhetoric, but in reality, they are not allocating more money for health. So don't expect too much. Worst of it, the graph on my right is how much governments are owing in terms of debt compared to the total value of their economy. That debt is increasing for all countries. So we are getting more debt to pay, and therefore less money to spend on social services that include health. To put that in real numbers, you can see this. This is how much African countries are spending on health. South Africa is one of the top spenders on health. It's about the second highest top spender in Africa. Most countries are below even global averages that are needed to make progress on the SDGs. South Africa somehow is spending what is reasonably good enough to make progress on the SDGs. So that's why I say, Dr. Percy said the truth. I will put a number on it that you need to look at what efficiencies. In terms of how much of the health budget is going to health workers as salaries, overall in Africa, 43% of every money spent on health goes to health worker salaries. Globally, it's about 57%. Here again, you can look for where your country is and then see whether you are doing more than the average on West South Africa. Close to 57. So here again, in terms of prioritizing how much is spent on health to pay health workers, South Africa prioritizes that more than most countries in Africa. Is almost at the level of global. And remember, when it comes to how much you are spending on health, you are also above Africa. You are close to, not really global, you are close to the big countries. So that means that it's a question of prioritization, and I'm coming back to that one. In Africa, if we were to employ all the workers we have trained who are not employed, we need additional 43% of our budget. 43%. South African numbers are also there, but I don't have it here. It's in one of the papers I showed earlier. You can look at the South African number. If we wanted to reduce the shortage of health workers in Africa by just half, we need to put in 77% more on the budget. So the question is, can we easily tell Treasury to give us that money? For you to decide how to tackle the argument with Treasury, we have looked at how the countries are prioritizing their health and their health workers. Country group 1, for them, the health sector is getting too little from the national budget, and health workers are getting little from their health budget. So for them, they can argue to get more. Group 2, they are prioritizing a bit more on health, but less for health workers. So the money is going to other things than worker salaries. Then group 3 is the opposite of the group 2. They prioritize more for health workers from so little they are getting from the national budget for health itself. That means they'll have little to buy the medicines and among others. Then in group 3, they prioritize enough or more for health itself, and from there, they also prioritize more than the original average for health workers. And this is where South Africa is, for that group 4. So in group 4, the best way to increase your ability to spend is to look at efficiency gains. So Dr. Percy just said it. I only put the evidence to what he said. Is to look at more efficiency gains than to say, just give us more money. So as I conclude on this, the labor market failures in Africa are characterized by having what? Fewer workers than we need. We have a shortage of 6.1 million. But at the same time, we have a paradox of unemployment, where 27% of health workers, trained, skilled, are not employed. And this is been exacerbated by, or that one is exacerbating, migration to high-income countries who, due to COVID-19, have woken up and they want to fill more positions because recruitment is cheaper than training and recruiting. This analysis in detail has been done for about 24 countries now in Africa. Those that you see on the screen are available online. You can download them. The others are not yet available online. I would encourage South Africa to dig deeper into its workforce situation by doing a labor market analysis. I would highly encourage that. And maybe Prof. Mabunda and colleagues, something we want to take as a research project with Dr. Percy. Now, this is just diagnosis. If you diagnose, what do? You need to find a solution. We think that so there was a charter adopted in 2024 called the Workforce Investment Charter, which was adopted in Windhoek, and thanks to South Africa for strongly supporting it. The charter says that when you do the evidence generation like this, have a dialogue between the Ministry of Health, Labor, Finance, and the regulatory bodies, professional associations, all of them, to agree on where to go as a country. And when you do that, do a joint planning, like South Africa already planned to do. Have a joint plan on what we are going to do with every partner or every stakeholder having their role very clear in that joint plan. And beyond just a plan, let every partner commit formally to their role by signing a memorandum of understanding, a compact, whatever name you give it in the national context, so that you can hold each other mutually accountable. And this, we should focus on having more investment in health where appropriate, in education, in jobs, but ensure efficient use of the resources that you have, and then ensure accountability. All of these are things Dr. Percy already mentioned. I've just put them in this framework for you. So Zimbabwe is one of our test countries that has done this. All of this process I talked about. They did a labor market analysis in 2022, did their joint planning to have a national strategy also in 2023, and from there, they agreed, picked out the things that require investment and developed a workforce investment plan. And that plan went to cabinet approved it, and they signed it officially as a compact between education minister, finance minister, labor minister, health minister, and there's another one, I forgot. There were 5 ministers on the side of government. And on the side of partners, the different stakeholders in the country, including the Global Fund, USAID, WHO, UNICEF, we also signed it, and then we have a mutual understanding of what our roles are and what we are going to put in. And so they now do a meeting every 2 months to check whether you have done your part and whether one has done their part. In this compact, the government promised to add $166 million of investment annually in the health workers. The Global Fund put $30 million for 3 years. I've forgotten what the other partners did, but different partners put in some amount, and they are tracking that. So they are implementing this. It's ending in 2020, end of 2026. We'll see how much progress they have made, and then what you can also learn from it. So as I thank you to take my seat, the issues are many. We need to invest more in the training of health workers and employing them. But more than that, we should spend more energy also to transform our education to be competency-based to address the quality issues. And to do so, we should focus on using evidence to inform our planning, our decision-making, our dialogues, and eventually we shall not remain the same. Thank you so much. If you are pleased with, please champion that we should invest more in health workers. Thank you.
I did know you were going to do it, going to clap for him, although I haven't said that. But if we were listening, really listening, these are preachers. They've preached by Teti Njalo. Antikunjalo? By Teti Njalo. Now they need us to ask them some questions so that they can answer the questions. But before I can give the mic to the audience, let me understand if Dr. Angel is online.
He's also part of the panel. Dr. Angel, are you online? Okay. At the moment, I'm handing over to the audience to have some questions to the panelists. I won't summarize or do anything because of time, but what I can say is I was having a question to Dr. Bayeni about the NPT, the NDP 2030, of what has happened in these 5 years. He has explained it thoroughly and very well. I won't do that. But now I'll hand over to the audience to have some questions to our panelists. I've got so many ends, and I'm going to limit them. The ones I'm seeing now are the last ones. No more. So the ones I'm seeing, let him have the count. I'll start there at the back. 1, 2, 3, 4, 5, coming down, 6, 7, 8. We start here from the front. Over to Dr.
Thank you very much. Zianda Mgugudosello from the South African Medical Association. I actually have a question for each one of them, but I'll just limit it to 2 questions, if that's okay.
Please.
Thank you. Thanks, Dr. Asamani, thank you for your presentation. Efficiencies are a big thing, and I think we're very clear as the South African Medical Association on how we need to improve efficiencies in our health system. So on to Dr. Percy and Dr. Luvuyo then, talking about efficiencies, 2 things I picked up. The first one about the unemployed doctors. We have about 1,048 of them that actually filled a survey, and 93% of those want to work in the public sector because that is where they get trained for specialty posts. So then my question to you is, in thinking about doing things differently, has the National Department of Health explored training these specialists in the private sector? So that's my first question. The second question is on the issue of overcrowding that you raised. Leveraging on the telemedicine as well as the virtual consultations that have been mentioned throughout the day. What has the Department of Health done or thought about utilizing the current human resources and even human resources outside the province to offer services to the 85% public sector patients that require them? Thanks.
To save more time, let the doctors respond on that. Is Dr.
Yeah, quickly on the one of training specialists in the private sector, it's already happening. I mean, the ophthalmologists, quite a number of them are trained in the private sector. I think it's a matter of ensuring that there is proper MOUs in place, I mean, the Pretoria Eye Center, I know that it actually does a lot of that. Around, yes, I would agree that people want exposure in the public service for purposes of training. But if the seniors are not there, who's going to train them? That is why then it's, I don't think it's a chicken and egg, but almost. That's why we've got to deal with those efficiencies. Around telemedicine, maybe Dr. Bayeni would talk about it, but so far I think the evidence has not been that good, in our country in terms of using telemedicine, as a mechanism. But he's more recent from clinical service. I left clinical service decades ago.
Thank you, Doc.
Thank you. No, I think the experience that public sector has had was to probably just want to rush and mix the issue of telemedicine. But if you listen today, there is a different approach we can explore, which is to say, let's start and explore with specialist services. Because in any case, if you consider the example that was made, those patients that are going to travel for oncology services are still going to meet the same specialist or the same cohort, but that cohort can consult them where they are. Instead of wanting to make it replace, or we think that it's going to replace general practitioner work or something. So I think that's where we might have missed it a bit when we want, because it's not a new concept in South Africa. Even here in Eastern Cape, at some stage, we had a demonstration of linking Cecilia Makiwan with Butterworth, saying that we are promoting telemedicine, but that has since died a natural death. So I think as long as we can have a different approach to say, maybe let's start with specialist services and let's be specific, which ones do we want to start with, and then we can see if that cannot give us the value add that we want. But the experience, unfortunately, from the public sector was, if you look back now, you say how much we've invested before and where are we now? Some of those gadgets are not working, some of those connectivity are not there. So we need to just make sure that this time around we are proper in terms of project management. Thanks.
We can continue with the questions. Here's a hand.
Thank you. I'd just like to thank all the speakers. The conversation and the presentations were very engaging. My question is for Dr. Bayeni and Dr. Percy. I'd like to start by saying that I've heard your presentations loud and clear, and I quite understand what you've said. But everything that's been said, I still have certain things that need clarity, just like any human would. The first thing is, have you considered clinical associates in your workforce planning going ahead? Because we know that, I think, looking at the Eastern Cape, the last time that clinical associates were hired was in 2021, and that was 18 out of a class of plus minus 50. Since then, we have had zero employment within it. And I do understand the reasons why, but it begs me to think about whether, what I'm trying to do is gauge whether clinical associates do have a future within the public sector. Thank you.
Okay, then the second question. There's the hand.
Good afternoon. I am Womgazi Majege, Dr. Majege, currently working at the Public Health Department in the Walter Sisulu University. Thank you so much to our presenters. I think my professor, I've learned a lot today. It has all have been eye-opening. But my question, I had a lot of questions, but I've just limited it to one. It's not even a question really. It's for Professor Jan, when he was speaking about financial protection in cancer care. It was just to highlight an issue that we're having in our region, that most of the out-of-pocket payments that are done by patients who are diagnosed with cancer, it's through accessibility or traveling. Some of them travel for 5 days from district hospital straight to the tertiary facility or oncology unit, and then they need to travel back, and some of them need to be accompanied. So that is breakfast, lunch, and supper for multiple people. And also their comfortability in terms of where they sleep, how they are accommodated. It's still a very sore and painful issue for us as healthcare workers to see. So I just wanted to highlight and ask if is there any plan in the future, after we are done with the project we're currently doing now, to do sub-studies or to expand on cancer care, especially looking at the district hospitals instead of screening and referral. Thank you.
Thank you. That's a third hand. And the fourth one, behind you, sir. Behind you.
Good afternoon. Thank you very much for the opportunity. There has been highlights, I think, from Dr. Jan on the issue of corruption, that one of the things that are frustrating the healthcare industry is the issue of corruption. And Dr. Bayeni also mentioned on point 4, on point 4 of their 5 goals, one of them is accountability of the of those who are in government or are in leadership. I think it says the optimal governance, ensure optimal governance and build capable and accountable strategic leadership in the management and management in the health system. What have you done to eliminate the corruption that is the one that is actually costing the healthcare industry? What has been done to eliminate the corruption and to hold the leadership that is responsible for the corruption? What have been done to eliminate those people? And number two, what has been done to employ people who are qualified to lead institutions instead of cater deployment?
Thank you. Then next, okay.
Thank you. I like to thank on all the speakers. My question is on quality. As Dr. Asaman has showed us that there's a problem of quality on our staff or of the health workers. So my question is on Dr. Pesi and Dr. Baeni. I just want to know what strategies are you having in place to ensure that healthy workers, both who are in system for the long time, because it does not mean if you've been long in the system you are competent, and the new workers, to ensure that they are on the same level of competency, and what plans are you having for the institutions that are training these healthy workers to ensure that at the exit level, they have same level of competency. There's no institution that is, say, someone who's trained in WSU is better from the other institution. And this quality has put our country in a lot of negligence and litigations. And if you look at the budget, it's a lot of billions that are going for litigations. I just want to know, after your audit as the department, what strategies have you put in place to ensure that the audit are put in place, the strategies that we identify in audit are put in place so that we won't lose this money, because these billions can be used to hire a lot of healthy workers who are unemployed. Thank you.
Thank you. The last two questions.
Good afternoon. My name is Sivuile Mange. I'm from Umtata Regional Hospital. In appreciating all the presentations that are so informative, I've got some concerns that I want to register. We talk of universal health coverage, of which that is NHI in the South African context as a funding model, of which the approach in realizing that is the primary health care, which is less expensive than curative. So my first concern, we have community healthcare workers that are believed to be cadres that are needed at primary healthcare level in strengthening the primary healthcare approach, that are still to be put in the system so that they are permanently employed. That's the first concern. And we know that NHI is about access to quality healthcare service. For that, we need resources. We have aging workforce, and that means we are going to lose them soon, especially the specialists. In the province, as we speak, we are sitting with a challenge of not producing specialist nurses for 3 consecutive years due to prolonged process of accrediting nursing education institution to offer these programs. Also, the implications of austerity measures in developing e-structure as a department, because the structure should be aligned to e-budget, not on the needs on the ground. Therefore, the issue of e-recruitment and retention, balancing it with the service delivery mandate, remains a big challenge if the Department of Health can't be exempted from austerity measures implemented by National Treasury. Also, the issue of upskilling the workforce to meet the changing times. We talk of 4th Industrial Revolution and AI, of which we need to adapt and not to be resistant to change. The last part is the issue of e-brain drain. Seemingly, we are still having a challenge that needs to be addressed in terms of e-brain drain. Thank you so much.
Thank you, Charge. The last one now. At the back. Oh, I've seen another, the real last.
Galata is
Dr.
my name.
Makola and the last one at the back. Only no more again.
Thank you, ma'am. From the Township Cannabis Incubator. I think my question is for Dr. Samani and also for Dr. Mahlati. I think there was a comment that was made on the private sector, because what seems to be obvious is that our health system is highly burdened. And I want to get an understanding whether has the department considered skilling our doctors, as I think it was indicated that if there are no opportunities in the public sector, it should not take them long for them to wait for that training in the public service before they can go open their own practices. Because I believe that if we could provide that support, that as soon as they are able to graduate, there is that private sector entrepreneurship support for them to start their own practices. My second question is on how, also from the WHO, Dr. Asamani, how is the WHO organization embracing the indigenous knowledge systems in tackling the health burden in Africa? Because I'm thinking that some of the solutions can also come from those traditional health practices so that we ease that overburdening of our public sector, matching that with the integration with the private support. So if perhaps we can maybe have an engagement on that, we'll appreciate.
Okay. The hand there, then last Dr. Makola, please.
Yes, so Dr. Bayani spoke to the 2030 HRH strategy goals, one being effective workforce planning. I just want to check what's been your assessment or progress made in that aspect, given recurrent challenges facing the sector. For instance, that of having yearly strikes at the beginning of the year, because already you know that you train and there's ComServe, doctors, nurses, pharmacists, who would need to be employed, especially in the public space. There's been reasons mentioned. I won't go over them again as to why they need to be retained by the public sector. What ways or answers have been there to effect this goal number one, or as you said? Thank you.
The last question, please. Okay.
No, thank you very much. Dr. Makola from Public Health. I just want to, the question to Dr. Mahlati and Dr. Bain. Taking note of the fact that we have a 60 billion rand shortfall in the coming financial year. I'm just, trying to find out from your comment in terms of how are the provinces potentially preparing themselves, because I think with that type of shortfall, there's definitely a likelihood that we are going to have a cut in the budget that becomes available for healthcare services. I'm just wondering as to whether, from a health workforce point of view, are you in any way interacting with provinces to make sure that they can start making the necessary adjustments and also planning in the context of that, realization that we are likely to face, cuts in the short to medium term. Thanks.
Thank you so much. Now let's, okay. Dr. Pierce want to talk first.
Yeah, because I want to take a few easy ones. The difficult ones I will leave for Luvuyo. Let me start with the one about doctors going into the private sector to set up their rooms. I think it would be fair to select doctors and say they must be assisted to set up their private practices. whilst nobody else is actually getting that. That's the space of entrepreneurship. I say that because for 10 years I was in private practice. You go and raise a loan, you take the risk, and you make sure that you are going to pay that loan back. Simple. Physiotherapists go to private practice. They can't expect that because they're not absorbed in government. Therefore, government must give them money to set up private practice. That is why I raised that issue in the pamphlet. Say that to some extent as medical professionals, there is some siege mentality. We feel we're under siege. We're not. We're not, colleagues. And there is no guarantee that if you are educated, supported by the state, that even when the state is undergoing serious problems, it must be obliged to be tied to support professionals. Colleagues, there are people who are so poor that they actually need to be supported by the state. There I come as a medical doctor, I say, no, prioritize me, leave those ones. No, we can't, colleagues. It's about values. That is what it is about. I know that I'll be cut to pieces for what I'm saying. Like I said earlier, I say it as I feel it. Maybe the age is allowing me to say so, and the experience. So that one, colleagues, even if you were to raise it, I would never support it. You actually take the risk yourself. Because the profits that you are going to make, you are not going to share even with the patients. That we know. We may say something else in public, but in private, we know what we do. Let me come to the next one. Accreditation of nursing programs at WSU. Slow process, but that slow process was produced by WSU itself. I will not go into detail, but I know very well about the accreditation of what we call PGDips, postgraduate diplomas in nursing. There were universities that actually sprang to actually put up their programs. WSU was one of those that was almost last in the process. So it's the internal processes that actually led to that. And by the way, something that we shared with your dean was that the divisions in nursing, you've got nursing at WSU and you've got Lilita College, they're not sharing any strategic vision. Those are some of the problems that we actually have to deal with. If it has been resolved, that would be great, you know, and would be very, very happy. Let me get to the second last. Colleagues, let's not confuse universal health coverage with National Health Insurance Fund or scheme. Those two things are not the same. You use the other to achieve the other. You actually use a better funding mechanism to achieve universal health coverage. Those two are not interchangeable. I know that communication sometimes has been that, you know, it's as if they're the same. You actually use better mechanisms of funding to be able to achieve coverage. But like Professor Mani said, the fact that you've got, you know, extensive, even 100% coverage doesn't mean that you've got quality. So there are various levels in there that you actually have to look at. Employing qualified people, it starts with leadership. 2023, we actually revamped a framework for governance and leadership, and we started with central hospitals like this one. 10 of them in the country that did not have, I mean, we've got 10 and 6 of them did not have leadership. It's unfortunate that the only central hospital that did the right thing was Groote Schuur. All others did not. And all others are not in the Western Cape. So we are again, because if you don't have the right kind of leadership right at the top, what kind of agenda are you going to set? But unfortunately, these are some of the issues that are above, even my pay grade, And I think others I'll leave to Dr. Bayeni to tackle.
Thank you, Doc.
Thank you very much. And it doesn't mean my pay grade is above his. Mine is even lower. So you can imagine how will I respond to some of them. Thank you very much. I think if maybe just to supplement the last one, the first 3 slides on leadership were actually taken from a presentation that was trying to talk to what caliber requirements that do we want for central hospitals. So that actually is part of the presentation that we did. So there is an intention from national. However, there are sometimes limitations that we don't run provinces. And some of the facilities then fall under provincial recruitment processes. The first one, clinical associates, an update, which is very exciting. Indeed, there has been a concern as to where does the department stand and what is the future of the clinical associates from a National Department of Health position. We opted that we don't want to use sentiments, we don't want to use influence from people, and that process has now been officially allocated for a program review, and the work is commissioned and it's going to be assisted by Health Systems Trust. So what that means is that there would be some work that will be done independent of us to go around the 3 facilities that are offering clinical associates, to interview the graduates from clinical associates program, as well as the facilities that have been placing clinical associates, to get a sense as to how then do we move forward in terms of the program. The new minister is awaiting that to inform what then becomes the agenda or the political position of the Department on Clinical Associates. So finally, we have managed to secure that support, so it will be undergoing that. Uboss, ubalekile accountability and corruption. Okay. No, I think colleagues, there is work from our side depending on what falls on our lap. The issue and the work we are doing on committed overtime, to me, talks to the very same thing of accountability and corruption. We've got facilities and institutions where doctors know that they have been getting paid for overtime, but they've never been even called out at night. And we are trying to correct that. So part of the committed overtime management plan that is in place is to try and improve on accountability. We're not saying that you are going to work for free for government, but we are saying we must pay you for having worked for government. And if you have not worked, we can't be paying you, unfortunately. We don't have that luxury and money anymore. If besinayo, maybe besizavala mehlo, but there is no money anymore. So there is work on the spheres of the committed overtime accountability issue. And of course, we do expect here that other issues that relate to corruption will be handled by the corruption agencies. Audit recommendations and what are we doing about those. The slide on strengthening clinical governance is what we are trying to remind. I think there was a bullet there that was saying we are even reminding that clinical audits are compulsory on a monthly basis at facilities. Because apart from just wanting to find the recommendations, there is a widespread lull in terms of the actual clinical audits taking place. So even if you were to say you want to act on the recommendations, some facilities don't even host and convene those clinical audits. So on the leadership, on clinical governance, it's what we are raising. And our message is clear that some of the issues that are costing us, we have been too quick to push them to a side. We say it's medical legal, we say legal must deal with it. Or we would say it's a question of maternal, we say maternal must deal with it. Whereas they could be better prevented if there was a strong clinical governance. And clinical governance is the one that is supposed to run and make sure that these audits take place, there are recommendations, there are improvement plans. So for us, if we could work with each other and improve on clinical governance issues, that will help us. What we're doing from a national point of view is to try and see how can we skill and support clinical managers and clinical governance. So we are in talks with the National School of Governance to say some of the courses they offer yes, they are available to public servants, but we feel we want to input that they can at least be tailor-made for the clinical setup in the health sector. So there is that work that we are doing to ensure that at least we can capacitate. Employment of community health workers. Yes, it came back from court last week. It's in the hands of the minister and review and consultation with the treasurer. So the leader of the nursing fraternity there, he knows exactly what he's asking. The minister will announce how we are going to respond to that order from the court that you are referring to. But we can safely commend colleagues that he has also expressed that the system needs healthcare workers. So it's just a question of the modalities as to how do we make use of them. We are not disputing that there is a value add and a role for them in terms of the delivering healthcare system in the country. The departmental structure, provinces are reporting different stages, but it's something that is a bit of a frustration for us. Because when we look across provinces, it seems as if officially most provinces are using 2012, 2008 structures, but when they report, they will tell you that, no, we got one that was approved, but we got one that is awaiting OTP. For Eastern Cape, we are in talking with DPSA and the Office of the Premier to see what progress has been made in terms of finalizing that work. So our support from national is to support provinces, but unfortunately, we can't interfere and impose. But we're working with DPSA to try and assist us into ensuring that at least some work is done. But it's true that there are frustrations that some of the structures are trying to lean towards budget over and above the need. And actually, we should be trying by identifying first what is the need and what we want to achieve before worrying about the budget. And thereafter, the presentation we did that financing must also respond to what we want to achieve, even if it might be difficult to fund everything. Budget shortfalls. In last week's meeting that we were having with DHET, we had invited my counterpart chief director from Treasury, who deals with health financing, a certain famous Dr. Mark Bletcher. He said to us, the meeting was on Tuesday before the budget speech that was postponed. He said, I can't talk about budget because things are in the budget speech and I don't know what is going to be said by the minister, even if I know. So there was that risk already we sensed last week that what we might hear might not be good news. The budget speech was postponed, but I am told today that provinces have been notified what their budget status is. And unfortunately, it will be provincial arrangements as to how that is catered into. If you come close to home, Eastern Cape, Treasury has already returned to Eastern Cape Department of Health to say, this is how your budget is going to look like. And there are areas where they are saying, we expect you to come with answers. One of them is got to do with committed overtime. I know tomorrow the department is having a meeting on that, which we'll participate in. So there is an indication as to there are things that must be done differently to accommodate the limited budget that is there. And I suppose the same thing will happen, that we might have to wait and hear by the MEC speech in terms of where are we going to feel the pinch and what else is going to happen. I think I've covered most of them. But just to maybe share them or alleviate fears, there is a consideration to say, whilst our professionals are undergoing internship and training, how can we assist them with the skilling of entrepreneurship? Not necessarily to fund. So there is that consideration that whether through a webinar or something, just some capacitation to say, as much as you are now undergoing internship and community service, should you intend to open a spaza shop, please look at these parameters, including going for a loan, including committing and taking the risk and whatever. So we are intending, from the ICSP point of view, to say, how can we enhance the program of placements as they are in the program of community service, if we cannot empower them through some service provider or some webinars, so that if someone is to consider, at least they are enlightened, because we know at undergrad currently there is nothing that goes close to entrepreneurship for healthcare workers. So we're going to see if we cannot try and impact that skill during the community service placements. Thank you.
Thank you, Doc. Prof, about the comment on cancer care.
Yes, I won't be long. Thank you for the question about the transportation and other costs. And unfortunately, there aren't many insurance programs around the world that cover those sorts of costs. Although we know from the limited studies that have been done that those costs can be quite crippling and prevent people from accessing care. The one exception I can think of is health equity funds in Cambodia, which is an experiment there to reimburse, at least in part, some of the transport costs that people experience when they go to hospital. I think it's tempting in a resource-constrained environment to think, well, those costs are probably not going to be affordable by government to cover. It's probably something one step too far. But, you know, for cancer care, particularly for early treatment and screening, there may be a strong economic case for doing that. If it's getting people to the clinic and getting them early, you're potentially saving costs further down the line. So there is a research question there that can be looked at, and it's potentially something that we could look into in that study that we talked about. But thank you for the question.
Yes, I think the questions that were directed to me were largely answered by Dr. Percy and the other colleagues. So I would just comment on the last one around whether WHO is considering to embrace indigenous medicine to address workforce shortages. Yes, indeed, indigenous medicine has been with us and they've played their role thus far. And going forward, it's not a question of if, it is a question of how we do it to use their potential to mitigate the workforce shortages that we are seeing. And to do so, the first thing to do is to understand who are they and what do they do. So that understanding of who are they and what do they do would allow us to see who exactly is doing what at where and how they have acquired their knowledge. And whether that knowledge, not all of them have their knowledge is consistent with what we know is safe practices. So who among them need their knowledge to be updated and all of that. So some work has already started at the global level, trying to review the status of, we call them traditional and complementary medicine, the work of traditional and complementary medicine practitioners. And so that work is ongoing. When it's completed, the next logical step is to have more discussion around it, to now think about having a framework to potentially regulate their practice so that there can also be accountability, but also come up with standardized curricula to more or less integrate their work more into the health system. For those that are trained at very reasonable levels, I know in some countries they are employed even by the public sector, and you go to a clinic and they will tell you, okay, your situation can be dealt by a normal doctor or a traditional doctor. So you choose where you want to go, and they actually refer cases to each other. So sometimes a doctor look at you and realize that they've done everything. The rest of it is, you need somebody who can speak the language you understand, and they refer you to a traditional person. Sometimes the traditional doctor also look at you and say, this one, you need a clinical doctor, and they refer you. So a few countries are doing so, but there's not been formal evaluation to see how effective it has been. Maybe that is one of the things that going forward we need to also think about, learning those lessons and helping others who may want to adopt it. Yeah, thank you so much.
I did know you're going to do it, but it is very legal. It can be bigger, please. Thank you so much. Those hands were for our presenters. They've done it very well. We are well informed now. We can go and practice some of what has been said here. Now I would like you to give some more hands for the audience. You had a very good audience who was listening, who participated and engaged the presenters. Your hands, please. Thank you. Now it's lunchtime, and the time is 3 o'clock. Is that true? It's 5 past, oh, it's 4 minutes. I'll tell now. It's 4 minutes past 3, and we are going to be back here at 3:30 to catch up with little that has been left. Then you can go home after that. Thank you so much.
We're gonna shoot straight and request that we welcome to present Ms. Kiriboni Make, who is an optometrist, but is currently doing a work for us at WSU in the Health Research Unit. And she's been asked to present South African rural provinces strategies to improve the availability, distribution, and skills mix of health workforce. Can we please give a round of applause, and over to you, Ms. Kiriboni.
Thank you for the introduction and good afternoon, everyone. I hope I'm audible enough and everyone can see my presentation.
Yes, you may proceed.
Okay, thank you. I will be exploring strategies implemented by the South African government to address the availability, distribution, and skill needs of the health workforce in rural provinces. Fortunately, previous speakers have extensively covered most of the important aspects, so I will just be touching on some of these aspects. So as it has been highlighted, inequitable distribution of healthcare professionals is a global crisis, significantly impacting the functionality of health services worldwide. So this challenge is particularly severe in low and middle income countries, where health systems face a dual burden, that is critical staff shortages and the uneven distribution of healthcare professionals. So this situation in low and middle income countries is further aggravated by the fragmented health systems and also the high burden of diseases. And one of the most damaging effects of this weakened and undersourced health system is the difficulty in producing, that is training, recruiting, and retaining health professionals, particularly in those remote and rural areas. So even in South Africa, just like many other low and middle income countries, struggles to ensure equitable access to healthcare, particularly in those rural provinces, includes effective staffing of rural healthcare facilities that is necessary to bridge the gap in healthcare access. So basically, our rural areas are the ones mostly affected by these shortages within the health workforce. So some contributing factors to the shortage of healthcare professionals in these areas include inadequate supervision, demanding working conditions, lack of infrastructure, equipment and drugs, and also lack of appropriate accommodation and schools for children professionals. And in addition to that, poor management of structures is also a huge problem. So it has been suggested that a country's ability to recruit and retain healthcare professionals in these underserved and rural areas ultimately depends on providing a stable, rewarding, and a fulfilling personal and professional environment. So while there are some health professionals who are willing to work in these rural areas, we really need strategies to persuade more of them to do so. So in response to these challenges, the National Department of Health has implemented health strategies to persuade health professionals to commit to working in these rural areas. So these strategies include clear policies on both financial and non-financial incentives, which are able to promote the retention of these health professionals in these remote areas. So we have government initiatives that involve yes, non-financial and financial strategies. And also there are policies that have been formulated by the government that includes your Human Resource for Health Strategy 2030. And also we have the coming national health insurance, which Dr. Baleni covered. So when it comes to the non-financial strategies, we have the mandatory community service, which has been implemented by the government for doctors, nurses, pharmacists, and other allied health professionals. So this initiative requires healthcare professionals to serve in underserved areas for a period of 1 year after completion of their studies. And also we have another initiative which requires registration of foreign qualified health professionals. And also there is bilateral agreements with other countries as some of these non-financial strategies. So one of the key principles of the policy on recruiting foreign health professionals is that they should be deployed to serve in underserved areas of South Africa. And they will only be registered to work in public health sectors. And also to support this initiative, South Africa has those bilateral agreements with countries such as Cuba that allow the government to bring doctors from outside countries to work in these rural and underserved areas. So there is also task delegation. So with task delegation, the department has also implemented a mid-level worker program to optimize service delivery. So these initiatives allows specific tasks traditionally performed by highly skilled professionals to be reassigned with appropriate training and supervision to healthcare professionals at a different level. So as part of this approach, the roles such as of those enrolled nurses and enrolled nurses assistants were expanded. And then again, new categories of mid-level workers were also implemented, such as the introduction of clinical associates, as well as introductions of therapy and occupational therapy assistant. So we also have financial strategies. So with they include your return of service schemes. These are in the form of bursaries and scholarships. So what provinces do is that they recruit students, particularly from rural areas. And provide them with funds to further their studies in health professionals upon completing their studies. And again, we have rural allowance. So the government has introduced a rural allowance policy. So this policy provides a non-pensionable fixed percentage allowance linked to the annual salary notch for most categories of healthcare professionals. So the primary objective of this policy was to attract and retain skilled professionals in rural and underserved areas. So by offering financial incentives, the policy aims to encourage health professionals to commit to full-time service in public health facilities in designated rural areas identified by those official health departments. So challenges that have been faced by the government is that while these strategies have been instrumental in addressing healthcare workforce challenges, it is also important to acknowledge that rural areas are still very different from urban areas. So rural communities will continue to face challenges related to education, communication, infrastructure, and transportation, which are not being experienced in urban areas. So these factors are considered to directly impact the ability to attract and retain healthcare professionals within rural areas. So as a result, these living and working conditions will remain a critical barrier to achieving equitable healthcare workforce distribution within rural areas. So it is important to address these broader socioeconomic challenges so as to achieve long-term success of rural healthcare initiatives. So as a call to action, as part of the recommendation, universities are advised to collaborate with local communities so as to provide medical students with hands-on community-based experiences. So institutions such as Walter Sisulu University also deserve some recognition because they prioritize community-based training as a key component of their medical education. So this approach, community-based education, it ensures that clinical graduates gain real-world exposure to the unique healthcare challenges faced in rural and underserved areas. That is including your limited resources, high disease burden, and staff shortages. So such experiences not only enhance their adaptability and problem-solving skills, but they also prepare these graduates for them to work effectively in this environment. And research has shown that medical students who undergo community-based training in rural settings, they are more likely to return and serve in similar communities after graduation. So strengthening these initiatives, it will be a crucial it will be crucial for building a sustainable healthcare workforce that meets the needs of South Africans. Thank you. I think that is the end of my presentation. Thank you.
Thank you very much, Kiriboni. Let's give you a round of applause once more. Please stay online, Kiriboni, but we're going to have one presentation and then we'll combine the questions for both of you. Moving right along, we are now going to be inviting for a presentation, second to last for the day, our host, to say the least. He's a South African trained public health medicine physician. He did his PhD, which was focusing on improving an understanding of how African governments have designed and implemented health professional training policies aimed at improving the provision of better care to underserved populations in selected Southern African countries. He has more than 15 years of research experience in African health system. Of late, he has been researching in Southeast Asia to draw lessons on their health system to address the growing burden of non-communicable diseases. He's an experienced manager in South Africa's public health sector and has served as a member of the Mpumalanga Provincial Premier's Advisory Committee on Health. He received his Bachelor of Medicine in Surgery and Public Health Medicine (MED) degrees at the University of Cape Town and went further to obtain his PhD from the University UNSW in Sydney. His passion in human resources for health and had his first Cochrane systemic review publication in this area in 2005. He has more than 50 peer-reviewed articles, mostly in health systems and human resources for health. He is the inaugural director for the Global Center for Human Resources for Health Intelligence at Walter Sisulu University in South Africa and is an associate dean for strategic affairs at the same institution. May you please join me in welcoming to the fore Professor Skhumbuzo Mabunda. Thank you.
Thank you, Program Director, for the kind words. I have the graveyard shift. The good thing about the graveyard shift is that no one is listening, so you can do whatever you want to do and sing and dance. May I first acknowledge the Abatembu Nation, who are the original owners of the land on which our university and hospital are built. I also acknowledge the current and future leaders present here today. Really, today I will, my presentation is made easier by the fact that everyone has spoken. All I can just say is that kila kaleu, everyone has spoken and I agree with everything that has been said. But I will just highlight a few points really, six, and we'll not delve as deep because anyway, colleagues have already covered everything. There are a few things that have not been mentioned. The challenges through scenarios. The William Peak report of 2001, I'm sure you have seen this many times. HRH policy challenges. Challenges of human resources for health in South Africa. And the question then of what value the Global Center for Human Resource for Health Intelligence will add. And it's getting some current challenges. I think if there's anything to take out of here is that before you start any project, check that you've got the necessary resources. This is me at some stage, believe it or not, I was once the tallest with my three brothers. The younger one being Education, that's his name. Education, that's his name. At the age of 12, teachers started noticing that when he was in class, apparently he was the cleverest in the class, but he had to sit in front of the class because he couldn't see properly. He was then taken to hospital, the nearest hospital to home in Mpumalanga, where I come from, my province. As you might see, this is a farm where we were. So when we went to the hospital, the doctor said, well, there's nothing we can do for you. There are no optometrists in the public sector. There are no specialists. What you need to do, continue sitting in front of the class. It was not until the age of 21 when he had to come stay with me, I was already a medical doctor at that stage, that he came back to me one day from uni. He says, a car almost hit me. I couldn't see the cars. I went blurry. At that stage, I recalled that he had a problem with his eyesight. I took him to the hospital where I worked. Initially, before I took him to the hospital, I took him to a private optometrist who was able to diagnose that there's a serious problem with this person. He needed to see a specialist. And I took him to the hospital where I worked in the public sector. I jumped the queue, yes, I did. He was then diagnosed with keratoconus. That needed an intervention. Generally, it needs eye lenses. And in some instances, an operation, like it did with him, because it had gone severe. So he had to have an operation. If you are to look around this country, I'm glad that an optometrist presented before me. Go around any public sector hospital and see how many optometrists you have. Actually, the question should be, how many optometrists are there within the public health sector in South Africa currently? Is it not essential care? I will go to a second story, also about my brother, Education. On the 26th of December, the morning of the 26th of December 2015, early hours, around 3 o'clock in the morning, I was called to be told that he had been involved in a car accident. I managed to get myself there with my other younger brother who's closest to me, also wearing a blue shirt. We got to where he was, the accident scene. The driver had died. He was still alive, but in hospital. I went to the bedside because I'm a medical doctor. I had to sit next to him. He has private medical insurance. He had private medical insurance because he was employed at that stage. Now, the public hospital where he was needed to transfer him to a private hospital. For him to be transferred, he was so severe that it required an ambulance. But unfortunately, we couldn't find an ambulance that had advanced health workers, paramedics, who would be able to transport him. As a result, we had to wait for over 4 hours. The next challenge was also that there was no neurosurgeon in the whole province, whether public or private, because it was the 26th of December. The 2 that were there in the whole province were on holiday at that stage. Now, that then tells us that with or without your medical insurance, when we do not have the adequate resources, sometimes it doesn't actually help to save you even. He demised later that night. Now, I'm just trying to highlight the fact that we are busy mostly talking about health professionals as if it's only limited to nurses and medical doctors, and dentists and pharmacists in some instances. But there are many cadres of health workers that are very important to us. We need to be able to decide as a country what is it that is actually necessary for us and be able to equip them appropriately. For a living, I speak to health workers across all sectors. I've been spending a lot of time with oncologists of late. I had a discussion with an oncologist as to why they had left the public health sector. And these are the reasons that the oncologist cited. There are delayed patient referrals to get to her. You can guess then that it's a female who was the oncologist. Patients take a long time to get to her. By the time they get to her, they are already advanced. There's nothing she can do. All she can do is to just look at them and really, if she prays and palliate them. At the same time, because these patients are already in late stages, so generally there's nothing that can be done. But then within her unit, there was a long waiting time as well. She was always exhausted whenever she got home. At the same time, some therapy that she feels she needs to learn and also is helpful for patients, such as immunotherapy and some targeted therapy for some types of cancer, is not there in the public health sector. So she felt that she needed to actually go to the private health sector to explore this. Sorry to bore you too much. The very last one. I've recently returned from Australia. A guy who came to my house to help install internet connection, a cable, found out that I had returned from Australia recently. His exclamation is, "Oh, so you were in Australia when they intentionally injected people with a disease in 2020. This disease was man-made," he says. It was man-made and was inoculated on individuals to lie to us that it was natural. They closed businesses and we were all suffering and people lost jobs. As we speak currently, in the city where I live called Buffalo City or East London, there is an outbreak of hand, foot, and mouth disease. Do we have the adequate and necessary public health care to handle or deal with misinformation, to manage outbreaks, or to even deal with any other condition? By the way, with any of these situations, including the oncology scenario, it could be any condition. It could be hypertension, it could be whatever else. This is exactly what it is we're experiencing from our patients. Delayed referrals and late diagnosis and long waiting times. If you are to go to any hospital, including the one where we're at now, go and see how the queues look like. Do we have an adequate supply of health professionals? You will answer that. From the peak report, many things have already been said, but I've highlighted one in green. Relate current resources and projected needs. So you need to be able to say, what is it that you need? What are the resources that are there? And how do you actually eventually get there? Unfortunately, this is where we fail mostly. We've not actually done our homework well. I'll jump this. Really, it's one of the PSEP report. Is one that looks what was funded by a private insurance company, foundation rather, Discovery, and also an independent organization to look at the projections of specialist medical professionals to 2040. And you can see most, by and large, there's going to be a shortage in 2040 for most of these specialists or specialties. Is the evidence for any of the policies that we have in human resources for health, be it rural allowance, be it compulsory service, we refer to it as community service, be it even commuted overtime? Another question that I know South Africans always pride themselves by saying we've got the best policies in the world, but they are poorly implemented. But is that the case? My argument generally from my research has been that we often do not actually plan well our policies. We don't develop them well. We think we develop them well. But possibly the intention of the policy is well. That's all that there is. But the reality is that the process of developing that policy, because it needs to tell you how you are going to be able to determine whether you have achieved what the policy said to actually achieve. That is the most important thing about any policy development. Then you can go to implementation and monitoring and evaluation. I will then cite an example that has been highlighted in a way by Prof. Joshi when she mentioned some of the work we did. We looked at 4 different countries in Southern Africa: Eswatini, Lesotho, Botswana, and South Africa. Eswatini and Lesotho do not have a medical school. Botswana has a medical school, with South Africa now having 10. In South Africa, we looked at all the 9 provinces. In Lesotho, we interacted with the Ministry of Labor, of Health, and the National Manpower Development Secretariat, which is responsible for training of any cadre in Lesotho. In Eswatini, the Ministry of Labor and Health. In Botswana, the Ministry of Education, equivalent to our Ministry of Higher Education in South Africa, and also the Ministry of Health. Return of service agreements, as has been highlighted, is what we would ordinarily refer to as bursaries. Health professional, aspirant health professional often is given funding in return for them going back to work for government. We'll get back to this as I say. But then one of the longest running agreements has been the South Africa-Cuba agreement, where health professionals are sent, medical professionals rather, are sent to Cuba to do medicine, and in return that they would come back and serve our country. My home province, Mpumalanga, has had its fair share, sending some to Russia as well. Part of the challenge is, as you might see from the objectives, with the Mpumalanga Russia agreement, professionals came back from Russia, and at the end of, when they return, upon their return rather, many could not be placed. Firstly, because they had to write a board exam from the Health Professions Council of South Africa. Something that had not been planned for in advance as to how they would actually go in and be integrated within the system. And as I highlight the different ways that we went about it, we looked at literature, we looked at the actual policies, we tried to examine and find the policy documents that founded this particular policy. We had in-depth interviews with policymakers. We looked at a cohort of every single provinces and countries an individual that would have been funded between the year 2000 and 2010. We wanted to understand. So you funded Sikhumbuzo Mabunda. On what basis did you fund Sikhumbuzo Mabunda? Or maybe before then. What actually informed the development of this particular policy? What are your views as policymakers on this particular policy? But what informed then the decision to fund Sikhumbuzo? Was it him being the top of his class or achieving good grades? Was it him being needy, needing financial assistance? Was it him being a rural environment? Was it him being identified and linked to a service area that he actually is needed in a particular service area upon completion of his studies? How then do you decide which profession you fund within the health sector? Is it based on the applicant's aspiration or is it based on the needs of the department? How much do these schemes cost? That's very important. How much do these schemes, and I have to declare, I'm a beneficiary of that scheme. You can guess from Mpumalanga. What are the factors that are associated with retention? How much funds are recovered from those who default? Because one of the conditions is that if you do not fulfill your contract, you need to actually pay back the money. How many do indeed pay back the money? As I said earlier, all provincial departments in South Africa were interviewed, and then these are the ones in the other countries. The reasons by policymakers was that they actually are going ahead with this policy because it's continuity. They found it there, so they have to continue the legacy. Some say, well, they have to address critical skills shortages. Some say it's social responsiveness to the needs of disadvantaged groups. And disadvantaged groups would be preference for individuals from Sichen racial groups. Some will be from low socioeconomic status. And also compliance with legislation as well. And other political reasons and agreements that governments would have reached, including the bilateral between Cuba and South Africa. The qualitative findings were that there was poor archiving. In South Africa, one of the poorest was that you couldn't find in any one province anything that tells you this is actually the reasons why this policy was documented, was actually founded, and this is when it was founded. The earliest we could track it to was 1950, but we couldn't find the actual origin. We were able to determine that with certainty in Lesotho, and we're able to determine that with certainty in Eswatini as well. In Botswana, almost with certainty around 1995 as well, because that is the newest. They were poorly coordinated between the various stakeholders and departments that actually are involved in the scheme. There was poor recovery of funds from those who were funded. And no evaluations of any of the schemes anywhere in these countries. And by the way, including in literature, you can look across and see which one has been evaluated. You won't find any. And some of these really, the biggest challenge really was the fact that lots of data was missing. If you look, those who know and are familiar with South Africa will tell you, I'm still, this is Botswana, Eswatini, and Lesotho. These are different programs and different countries where they go to, mostly biased towards medicine. So that decision again is mostly based on who applies. But I was saying about South Africa, those who are familiar with South Africa, you will realize that KZN, KwaZulu-Natal province, has the biggest scheme of all the provinces over time. But you will see between 2003 and 2005, there is no one represented there because there's no data that you could find. For many of the provinces, including Eastern Cape where we are today, they couldn't find data of anyone who was funded to study in South Africa. The only data that you could find was for some period for those who studied in Cuba, medicine. The question then is, what were you investing on? Even then, on money, how much money did you pump into this program? None could actually tell you. Sorry. As you look at the numbers. The little that we had on compliance, on service compliance, was that there was a high defaulter rate generally between the units that we assessed. Where you would ordinarily expect an equal duration, almost equal duration, an almost equal duration of the funding period and the service duration, or if anything really, the service duration should be longer. But by far, people were funded for long, about 5 years, and they only gave back less than 2 years. That's more than 50% of them. And factors that are known, I mean, a person doing community service is not supposed to undertake, that's in South Africa. A person doing community service is not supposed to undertake community service in another province if they were funded by government. But we found this happening here. It is also at this point that it's important to mention a few things. Some of the individuals could not be employed by government. They completed their studies, but could not be employed. Now, that's where the unfairness comes in. Individuals sign a contract that if you default, you have to repay government because you are meant to serve government. But if government is the one who defaults, that doesn't reciprocate. It's also an opportune moment to also mention that part of the challenges that there is as well, those registered, health professionals who are registered with the Health Professions Council of South Africa cannot readily be employed by the private sector. So it's very important to also highlight that nurses are different. They're not registered with the HPSA, the Health Professions Council of South Africa, but all the others cannot readily be employed by the private sector. The only way would really be them being partners or actually opening their own, which limits their options really to mostly the public sector. That's why there's the feeling that doctors might feel entitled. And we see that in evidence as well. Is this a worthy investment, this particular scheme? What we found is that you put in $100, you get back, you lose almost $48 through defaulting. We can't actually for sure tell how much return of service schemes cost government, but it's a lot of money. And I think if you've invested that much money, you need to at least get something for it. And part of what we need to do as a unit is to really understand what is the true value of a health professional. You health economists will advise me. What value do you attach to a health professional that you have trained now? So we need to be able to get to that. And different cadres will have different values, and for us to be able to say how much investment is this worth. The South Africa-Cuba agreement is such that those who studied in Cuba cost 5 times more than those who studied in South Africa. And we increased those in large numbers between 2010 and 2012. 3 cohorts of 1,000 each. That also increased the so-called supply. Because we hadn't planned for that, it's then difficult to factor them in as to how they actually go into the system. But when you give them when the bursaries are awarded or the ROS schemes are awarded, there is no planning as to where in the health system they are going to be, how much money they are going to consume. So the question is the only problem about implementation of policies? And I will tell you, it's definitely not. It's bigger than that. And part of these challenges as well, we don't change much the skills mix of health professionals, because it's really dependent on who applies and who we find. It's not based on needs that we have as the health system. And needs, I'm referring to evidence-based needs, not needs that we look at and say what posts are vacant and what actually is required. That is not a need. That is just what is there. And there is the current process, the plans and wishes ready. The plan is that, we have the shortage of health workers, and then you will wish that, you will eventually have people returning. But unfortunately, the complexities are such that there's a maze. There are many processes at play. And all of them really need to actually be examined at once. And if we summarize them in 4 phases really, say the planning, implementation, monitoring, and evaluation need to all be coordinated. And again, I'm not a Nobel Prize candidate, because many of these things have already been said before. The challenges have long been known. Smith and colleagues actually summarized this very well. There is poor human resource for health planning within the country. There is geographic maldistribution. And not just South Africa, by the way, across the board. Poor interface between the training platform and health facilities. And then in 2018, they referred to a large number of unplaced junior doctors. So where then do we see ourselves fit in? We are a global center located in South Africa, but serving the needs of low middle income countries, mostly in Africa. We want to serve the needs. Yes, charity begins at home. We would like to work with the South African government. We would like to work with any other government in Africa. We would like to work with many organizations, as I will highlight later. But then we want to cover 4 areas by and large: the availability, distribution, competence, and wellness of health workers. And as Professor Mann highlighted, part of the challenges is competence. We assume that people have been trained, therefore they've got all the skills. But actually that's where we need to go and focus more. And we're going to invest on all these areas and make sure that we've got science behind everything we do. Our capacity really will be on technical assistance, assisting with human resource for health strategies, epidemiological research, because everything needs to be based on who, where, and when actually people get affected by conditions or health needs or deficiencies for that matter. Health system strengthening, policy analysis, and then also there's education and training, naturally because we're an academic institution, but at the same time because we're focusing on competence as well. Data analytics and visualizations. And we also include, as one of the many things, as we're celebrating 40 years of our existence as a university, faculty rather, of medicine and health sciences. We want to include tracking of graduates and employees, for anyone who actually requests for our assistance. Have employee dashboards, look at efficiency measures and also absenteeisms and turnovers and all that. And monitoring and evaluation. We would like to build lots of partnerships. We've already begun with many of the esteemed guests being here today. We really appreciate and are humbled by the presence of these colleagues. And we hope that we'll grow from there, from strength to strength, build more relationships with governments, and I don't say governments, international institutes and organizations, academic institutions. We can do better if we put our heads together. No one has got monopoly to good ideas. Let's share those ideas and work together for actually making sure that our people's lives get better. That's all we need. We can't expect a different result if you keep doing the same thing. You need to innovate and get better and learn from your mistakes. This is an example of Nokia, which was doing well initially, but today is really not there because they never moved with the times, which is what we need to be able to do in health workforce planning. We need to be able to move and adapt with the times. Come together and say, do we need to remodel the way health workers are actually operating at the moment to better use them? Do we need to repurpose some of our health facilities, as a matter of fact? So these are discussions that we need to look at. And again, working together, we can do more. I'm not stealing anyone's slogan. Thank you. And I think it's opportune for me to also, because I'm a researcher, for a living I speak to health workers. And by the way, this was prepared way before Dr. Bayeni and Dr. Mahlati actually took to the podium. Commuted overtime is one of the biggest contentious issues that come up at dinner parties. It's important to highlight that this is based on need. It's not an entitlement, and it should never be. I previously, in my first stint at Walter Sisulu University, I would have taught medical students between 2015 and 2018. A lesson I would always tell them: do not plan your life based on variables. A variable can be taken away at any time. Rural allowance, commuted overtime, and so on are variables that can be taken at any time. Don't plan your life based on that. That's the first thing. But then, just to bring on board, because I'm aware that there's an international audience and other people online who are listening who might not be familiar with this concept of commuted overtime. Really, it's fixed overtime where generally, and it's not the same as simple as this, but then I'll simplify it and say a medical professional is paid an extra 53% of their basic salary for rendering a service after hours. It's about 80 hours per month. Again, this is the simplest version. That's the largest proportion of medical professionals. So if a person is getting paid 100 rands, I'm using South African currency, as a total cost to employer on the letter, the basic salary will be 70 rands. The commuted overtime will be 53% of that 70 rands, not of the 100 rands. So that will amount to about 87 rands. So that really is what a commuted overtime generally is, and that is a contentious issue then. Now, the impression then is that there are more health professionals or medical doctors, because it's mostly limited to medical doctors. Then we should change this, how this works. The importance is that it might well be the truth. I just recall teaching I received from the University of Cape Town when I was a medical student. One, Professor Vanessa Pesh, she said to me, and us in class, whenever you have a single diagnosis, you must consider that you might be wrong. Always have a differential diagnosis. Then in that way, you know you have thought well and given every single possibility a thought. So what we need to do is to really go to a drawing board and sit down and look at all the factors in detail and not superficially thinking that if you take this one away, then you're going to solve the problem. Is it going to be the magic bullet? We would have taken scarce skills allowance at some stage. What next might be rural allowance, it might be something else. But the reality might be that patients might end up suffering. Let's make sure that we do a thorough homework and do our basics well. Because currently, what is noted generally is that some provinces now, as we speak, are actually projected to underspend on their human resource for health budget. by the 31st of March. That's the reality. The reality is that we've got not just doctors unemployed, we've got many other cadres of health professionals. Are we only considering bringing in the unemployed doctors because probably they're making the most noise? But let's look at all the other cadres. What are our needs and what it is that we can do together? Let's identify all areas of wastage. There are those, yes, who are obviously being paid for commuted overtime when they do not even engage in it. Let's make sure we identify clearly those areas of waste, including even reviewing some other policies, as you mentioned earlier, Dr. Bayeni. Do we still need district clinical specialist teams? Are they relevant, really? Are they evidence-based, as a matter of fact, that those particular identified specialties are the ones that we need in the health system? Renefeld and colleagues in 2020 wrote an amazing article, Schneider and Archer-Liman. They say really what we need to look at is, one, good governance, and that is formed by a number of facets: capable stewardship, appropriate mix of technical and administrative skills, and explicit political support. And political support is not limited to the Ministry of Health. It's across all the major departments. You mentioned Department of Higher Education and Training, you mentioned Treasury, bring on board the PSA as well, Department of Public Service Administration, the employer. All of them in one room and speak in one language and coordinated, understanding what it is we want to achieve for our population. Then they would have moved further. As I said earlier, eliminate the waste in the health system. Academics are there to serve the people of this country. Let us be there to assist you. And as a center, we are open to that and would like to actually be part of the solution. Share all the data that is necessary. And again, as I said, areas of waste might be the major issue that we need to touch on. And it's important to employ the health professionals. Professor Mann has shown that we actually do not have enough. And as I said, we need to be able to look at the day when we're saying that patients do not have long waiting times, patients do not take long to be referred, patients like my brother get actually assisted with the needed care that they need when they need it, then we can say we've got enough health professionals. And we make sure that this year's shortfalls or any other year behind us do not recur. I think I've said a lot. Thank you.
Thank you very much, Prof, for that resounding closing presentation. Can we give him a round of applause once more? All right. I am told that the Dean is going to make a plan, and he always keeps to his promise. For the disappointment I am expected to deliver, that we might not have time to engage with the last two presentations due to another pressing commitment that some of the presenters as well as the executive of the department is expected to engage in, which was scheduled for 16:30 with the department to solve these issues. You said we must partner with provinces as academics. Yes. So we have been requested to humbly apologize, as we might not be able to interact with the last two presentations, and sincere apologies for that. And in case I misrepresented the Dean about the promise to make it up to you, he's gonna come to the fore and explain exactly how he's gonna make it up to you, or correct me if I misrepresented him. Now we are coming to the part where we are just gonna have closing remarks from the Dean in terms of how the day has gone. And let's give him a round of applause as we welcome him to the stage. Thank you.
Good afternoon, everyone. I must really apologize. We did go a little bit beyond time. And, you know, when you are going to negotiate, you don't make the people where you want concessions to wait for too long for you. So I want to apologize for interrupting the program. But before I proceed with my difficult task, I just want us to give a good round of applause to Professor Mabunda for launching the new center at WSU. Colleagues, you know we've come a long way, and we've been having building blocks towards today, and he has been made the founding stone to make sure other blocks can stick, and he has agreed to take the responsibility and lead the way. Ours is to support him. You have heard him talking, you have felt the passion. And what I like, his last slide, the passion for solutions, and urging all of us to partner with him and his team on his journey to find solutions, not to create more problems. We have enough problems. We need a bag of solutions, and I am sure he's capable of leading us in that. So I want to thank him for taking, that responsibility. But also, before I forget, that I don't get carried away, it's important, to thank the whole audience for being here, taking time, sticking out the whole day, short breaks in between. But I think let's give each other a good round of applause for that. Because I'm going to forget the organizers of this, I understand there's a very good attendance even online. People have been sending messages to me asking for the links and all that. So the organizers who brought us together to spend today on this important area of our work, I think let's give them a good round of applause. So here at home, we appreciate the visitors first. And without wasting time, we've had a good array of presentations in various areas of the work that we will be working on, taking stock of where things are, but also getting ideas on how to take the work forward. I'm sure we have taken lessons, as the team here, on things to build on. So there are certain people I will just touch on. Professor Joshi, we treat her as one of our own. She has been with us now for some time. We have been working with the team in public health, and as the work that we've been doing, coaching, mentoring, assisting with looking for funding opportunities, that work we appreciate. So today she presented on the future of the health workforce and emphasizing on the challenges and opportunities. She highlighted, I think, some key points that I think I would love to touch on here as part of our homework. Firstly, she actually opened this platform and provided a scene using the health systems building blocks and emphasized key areas in them. One of them is obviously human resources, area of leadership and governance. She emphasized the role of community health workers in promoting community health systems, and also use of digital technology as an enabler for health worker performance, not as a negative, a barrier, as an enabler for health worker performance. So we are taking that message home because of where we are. We got a presentation from Dr. Thomas, where he left us with a homework on the Smart Health Program. Yes, he presented from the perspective of their experience in Indonesia, but I'm sure you all heard Dr. Mahlati when touching on it, that he doesn't dispute the need for it and the need for programs of that nature, but he just was raising other issues which are local issues. I'm sure Mr. Lugege knows, the local issues on softwares. But the reality is that the programs, we will explore how far we can go with this. And I'm leaving it with the public health team to discuss and see what is it that we can do. There are lessons that we picked there. So we would love to leverage on the use of technology to balance HR constraints in the environment where we are. So that's our appreciation, Dr. Thomas, for the presentation. And Dr. Blake, covered an important part of this discussion. And I suspect it might be the foundational part of the discussion. And often you don't find it in most of the policies. In South Africa, we have been made to believe that we've got the best constitution in the world. From whose perspective? Yeah? We are number one in terms of, the, what do you call it? But we're number one in almost everything that is not going right. And we must blame something. And one of the foundation documents guiding our life, our Bible, is the Constitution of the Republic of South Africa. And the highest unemployment we'll find is manufactured by the best constitution in the world. And we go on to celebrate, vote in every administration, and celebrate the same people who put us deep and deep into poverty. So with the best constitution in the world, with the worst poverty you can find, highest unemployment rate you can ever find. So he says there is insufficient economic evidence guiding investment in non-traditional models of care. Nobody can dispute that. We meet, plan, change a system, no evidence has been presented. Somebody has just come and says, I want a clinic here. I have promised a clinic. So we're sitting with that problem 30 years into our democracy. When are we going to learn? He also emphasized the important point, which is true, the importance of strategic investments in health workforce. It is not expenditure. It is an investment. We cannot be compared to many sectors that exist because we are a key contributor to an inclusive economy, as Dr. Bayane was saying. So we talk too much about expenses. Like now, somebody said in one session, now we've got an oversupply of doctors because of medical schools like Walter Sisulu University. I'm sure you heard that one. Yes. That's the mistake that we are going to feed the community. The communities, they go to the hospitals, they don't find doctors. What evidence do you need to go and say you've got an oversupply? When you can't afford to run a sponsor shop, you say now you don't need the sponsor shop. So this gentleman reminds about the strategic investment on that. But if I highlight something that I think Professor Mabunda touched on, in his presentation, shortcomings in policy leading to minimal or unclear impact. We claim something is working because it is analyzed to suit a particular narrative without really doing proper work, and you go and make that noise. Now we've got multiple HRH strategies or so-called incentives with no evidence of whether they assist or they don't assist. He also touched on an important point that says there's a need to focus on community assets, capitalize on their strengths in order to close capacity gaps. We sometimes want to import things when we've got our own strengths, but we're failing to appreciate and take advantage of them. But also a very important point for us, because we're in the battle for the mid-level workers. The system since '94 has undermined the role of mid-level workers. There is no champion for them. You are led by curatively minded leadership or managers. They think pills and tablets. They think stethoscope before they think the community. And those are our policymakers. So here he says, When properly supported and supervised, many interventions led by non-physicians or non-specialists can be cost effective. Imali iphelile ke ngoku. Bayidlile amasela, ayizobuya. We need to look at alternatives, alternative models, and the cheaper models, so that you can stretch the dollar. We need that. Iphelile amasela azanishiya xa iphelile nizosala nisilwa edamini. Nizibona ingwenya xa zifika edamini li-dry. That's what is already happening. They are chewing each other. Ours is to save ourselves. We will not be saved by politicians. We will be saving ourselves. The journey starts now. Last point, I think I've touched on it, interestingly touched on it as well. Health worker corruption has been seen as an intractable problem for many years. What are we doing about it? Yeah, I was chatting to someone earlier on that he knows my role in my capacity as a dean, Professor Steve, is I'm a head of a WSU academic health platform. It includes facilities managed from both sides of government and university resources put together in order to be able to produce the health professionals we have. Now, what I have learned, which I have not said in public, Sukumbuzo, I'll say it for the first time today. I have never imagined in my lifetime that I could coexist with a captured hospital. Nah, I've never thought that South Africa would get to that. That is what you are faced with now. It's time to take the baton, face it head on, make proper decisions. One decision starts with being a voter. So he says health worker corruption has been seen as an intractable problem for many years. I am saying I have never thought I could coexist with a captured hospital. It's an unfortunate consequence of failure to intervene. So Professor Steve, very important point again, he gives a great input. A take home for me is that economic disadvantage as a determinant of health. Ne? Siyathanda ke uba sihambe sisithi siphuwa. Clever kakhulu, si-rich la. Lady, we need to create an environment conducive for us to deploy our resources correctly. Ne? Yes, economic disadvantage is a disadvantage. Ne? But we know we have had many barriers and we have tried to deal with them. Some we have dealt them successfully. Even the ones that we encounter today, we will deal with them. It's a matter of time. He touches on a very important aspect of the work which has become common today. We experience it now every day, left and right. Catastrophic costs associated with illness. Ne? We're losing jobs, whether it's COVID or something else. We travel long distances to care. We are told now our specialists must work around where they are. They can't go to where we need them. We are given all the stories. I said, you are the voter. Probably it's time to go and think. He also highlights a very important aspect, of what we have become, what has been increasingly experienced or transferred to patients, out-of-pocket costs associated with access to care. For those families that have got sick people, but also for the health outcomes that we expect. very interesting part, that I think we must note, because we're sitting with also a very difficult burden of disease, with the NCT component. You know, take home financial protection for NCDs is generally not commercially viable. You have nowhere else to go. Ne? So your vote is very important. Remember, today we talk about the national health insurance. There are those who are for and there are those who are against. Ne? I listened to some of us. I thought we were better educated, but some of the arguments we forget that all of us are ending up there, by the way, with those NCDs. Ne? One day you will not be insured. Ne? Where should you go? Nditi? The capacity of the state to ensure that all the vulnerable and the needy are taken care of needs to be protected at all costs. So he's reminding us that financial protection for NCDs is generally not commercially viable. So no investor wants to put the money where they're not going to make profit. So, Dr. Bayeni, you have covered everything. I appreciate it, my brother. You reminded us on the goals of the HRH strategy. You shared progress, of that. You even told us that our clinical governance is generally poor and it contributes to wastage. But we know the answers. There's evidence out there of what works and what does not work. We have got a failure to take evidence to policy and practice. You see, when I studied in the early 90s and early 2000s, government of the Republic of South Africa was working very well with universities and university research centers. Today, they've diverted and created things that you never understand why they are doing them, because they are not their mandate. They've created animals called the School of Government. I'm not against government working on developing a capable developmental state. I support that. But it does not mean you must take away mandates of other institutions of society for things that they can do better than you. I see the development of that School of Government as undermining the role of universities in South Africa. It's important sometimes to speak the truth, so that the message, I like this thing, is recorded. So it can go for years. You see, as much as somewhere else it has been copied, there it is working, and we know why it is working. But here we're in a different environment. I can tell you one day that thing is going to be caught on corruption and caught on everything else and all that. It's me saying that, unfortunately, I've gone out of hand. Professor Asamani, you remind us on important things that we have forgotten. And we pretend that we understand. That more health workers are needed than currently available. You heard me earlier on, one of our political leaders in a public platform said we have got an oversupply of doctors. I mean today. That was said last week. You remind us there is a need to train more. There can be frustrations in terms of absorption in the market and all that, but the need remains there. But you also remind us that immigration is here to stay. We are part of the global village. There will be movements. Perhaps what we should be visiting, in the past, we looked at the human rights component of immigration. We went to an extent of developing ethical codes for recruitment. And those ethical codes these days are being breached left and right. Nobody is enforcing anything. Nobody is following up. Why are we doing these things? Private sector in South Africa continues to steal from the public sector without anybody holding them accountable. They have become good friends of government. They say we'll donate money and steal your people. So they donate 10 rand and steal R1 billion. You remind us again that the level of production where we are will not be enough to sustain the country in the future. There is a need to change course. When are we going to change course? We're busy writing documents. You heard Dr. Bayenimus. He's my brother. We're busy writing documents. On one side, you are writing document. On the other, you are pushing them to the street. What are you writing the document for? So, in those words, I want to thank you for the input. I just wanted to touch on some points that I got from the message that, Chief, the task is big, but I believe you are equal to the task. You know, we'll support him, also. Yes. So, I want to thank you for taking time to be with us today. I hope you have tasted our mngusho and mleqwa, and you'll come back. Ne? I want to say I want more time for some people. Come, we work together here. Hopefully we'll explore modalities in order to achieve some of the things. So in those few words, I want to thank everyone for being here in this great symposium. I'm pretty sure the university is happy. We are happy to be part of the national discourse, and the points discussed here will definitely be talked about out there, I'm pretty sure. I said I must take the opportunity to be provocative a little bit so that in the social media they can write about me as well. You know, so without wasting time, thanks program directors. You have managed to drive us. It was a great program and with your great direction. I'm pretty sure there's a lot that we'll do together on that. I want to endorse what Skumbuzo said. National government want access to data. Thank you.
Thank you very much, Dean. Let's give him a round of applause once more. We have reached the end of our program for the day.